I can. Omkar, I think you are here, right? We'll wait for a couple of minutes. Vasant sir is yet to join. So,
Hello, sir. Sir, Vasant sir is also with me only. So,
कोई दिख नहीं रहा है वसंत सर कहाँ गए?
so basically we are in the same cabin.
Oh, अच्छा. Hi, sir. Sir, give me a couple of minutes, sir. Let people join. Average around 50, 60 people are joining. Just, okay, sir.
हेलो। ब्लड बैंक नवीन आपसे बात कर रहे हैं। मैं रंजित सर सिंह सिंथेटिक पेश पे 33 मैंने कॉल किया था। मनीषा का बात हुआ है। अपनी तक एबीओ ब्लड रिलीज कर लिया। अभी क्या चेक इन द ड्राफ्ट।
Hi, Nia.
Okay, I think we start now. It's 5:05. Normally, we always start bang on time. So, uh, today, the last day for the year in review. For the people who have joined new today, this is an annual event that we do and where we try to uh, discuss about whatever had happened in the last year. So in this case, it is 2024. And happening means what is the new thing that had happened, what innovations, what new articles that have changed practices, then new discovery, new inventions, tech innovations, AI related work, newer drugs, newer therapy. So all these things would be included, or anything that the presenter thinks that think that it could help people to uh, sharpen their clinical skill and their practice itself. And also at the end, our experts might predict that what would happen in this coming year. That's why we very strategically place it on January, so that we can review the previous year and we can predict the ongoing year itself. And then when we go to the next year, uh, 1 year after, then we at times can look into whether our predictions have worked or not. So, and in that way, we have divided critical care into 16 subspecialty. So we always ask our presenter to present on that specialty, but with with a very clear connotation or a connection with the critical care itself. So maybe so today when we have infectious disease, so most of the infectious disease issues had to be related to critical care or directly from the critical care infectious disease itself. So that's how we would be doing it. So we have a couple of presenters for each subspecialty, and then we do have a moderator who would moderate or take up the questions and all others. And lastly, we have the a bunch of very senior domain experts who will comment on certain aspects of the presentation depending upon how the moderator is going to ask. So each and everyone has a unique uh, role to play, and we have uh, four different topics today. So we will start with infectious disease today, followed by respiratory support and pulmonology, which is mostly covering invasive and non-invasive ventilation. Then we have medical and surgical gastroenterology, but mostly we'll be covering medical, I presume, and then endocrine and critical care. So we'll start with infectious disease. And to present, we have Dr. Omkar Borde, who is a junior consultant in infectious disease, Sir H.N. Reliance Foundation Hospital. And the moderation would be done by none other than Dr. Vasan Nagvekar, sir, who is uh, director and senior consultant of infectious disease, Sir H.N. Reliance Foundation Hospital, and also senior consultant in Lilavati Hospital, and presently the general secretary for Clinical Infectious Disease Society of India. And we have Dr. Aruna Pujari, madam, from Bridge Candy Hospital. We have Dr. Shalmuli Inamdar, uh, who had been our colleague, but now she is a consultant in Kokilaban Dhirubhai Ambani Hospital, Mumbai. Dr. Ashwini Tayade, and uh, Ashwini ji is now the consultant infectious disease and adult vaccination expert in and she has been qualified in infectious disease, tropical medicine, as well as from India and US itself. We have Dr. Neha Gupta, and she has also been our colleague, but now she has moved on to Gujarat itself, and she specializes in many of the aspects of of infectious disease like transplant and cardiology. And also we have Dr. Laxman Jesani, and he's an ID physician and infection control specialist, board certified, and in Mumbai and Navi Mumbai. And so, if anything I have missed, Dr. Vasant will also at times will compensate on that. So, sir, all up to you. My request is that if there are multiple segments of Omkar's presentation, I would rather suggest you, sir, because that's how we do it in that after each segment, if you ask the experts to comment on, because if the presenter is presenting too many subsegments, maybe 7 8 or something, at the end it gets little jumbled up. So it's better to take the segment wise or the topic wise itself.
Correct.
Is that
Thank
okay, sir?
Just about Neha is from Gurgaon. Delhi. So,
Yes, sorry.
mm,
Sorry, sir. Sorry, sir.
right.
My mistake.
Okay. So, I think this for 2025, 2024 year in review. So, we have none other than Dr. Omkar Bode, who's been there with us for more than 2 years and as a junior consultant, and he'll be presenting. And I think after 3 or 4 topics we'll cover, depending on the time. And after every topic, we'll take a pause and just take comments from the experts panel who are there. So, Omkar, you can start.
Yes, sir.
Am I audible, sir? Hello?
Yes, you are.
Hello?
Yes, Omkar.
Hello? Am I audible?
Yes, you're audible and your slides are visible too. Full screen. You're ready to go.
Okay. First of all, a very good evening to all my respected faculties and colleagues. I would like to thank the Department of Critical Care at HN Reliance for providing me with this opportunity to discuss a review in the subject of infectious diseases in the last year. So I will proceed with my topics for today. So first we'll be discussing four main topics. So starting with the first topic, what is new in infective endocarditis? So with the changing epidemiology, there is evolution in the diagnostic modalities as well as the guideline recommendations for effective utilization of the imaging modalities to diagnose the infective endocarditis as well as its complication. The antibiotic regimens are also advancing, wherein the implementation of appropriate treatment duration as well as early switch to oral antibiotic regimens in case of eye. Certain specific populations require a unique treatment, such as intracardiac device infections or those with a high surgical risk. And all of this is complicated. So, an integrated approach is required with the principles of multidisciplinary management into this endocarditis care. These are few guidelines in the recent 2 years, wherein the Duke International Society has revised the Duke's modified criteria for infective endocarditis. We have the ESC guidelines for the management of endocarditis year 2023, as well as an update on the cardiovascular implantable electronic devices infections and their prevention and diagnosis with the management. Proceeding. So in this, the 2023 Duke International Society, what has updated is there is new microbiological diagnostic assays added in the form of enzyme immunoassays, specifically for Bartonella polymerase chain reactions, as well as metagenomics, including next generation sequencing. In the imaging modalities, we have included PET, cardiac CT, and also included that the surgical major criteria, that is intraoperative infection of a new major criteria which doesn't require supporting evidence of histopathology or positive imaging modality. There is a list of typical microorganisms which has expanded, which includes not only the typical staph aureus, staph streptococcus organisms, but in certain conditions wherein the patients have intracardiac prosthesis, the typical microorganism domain has been expanded. The requirements of timing and separate venipunctures for blood cultures has been removed. And lastly, predisposing conditions such as TAVR, endovascular implantable cardiac devices were clarified. So these are the definitions for definitive endocarditis possible, and the wherein the endocarditis diagnosis has been rejected. So in the pathological criteria, the things which has been added are the microorganism identified in the context of clinical signs and symptoms of active endocarditis in a vegetation, a cardiac tissue, explanted valve, or a aortic graft, or from an arterial thrombus, or an active endocarditis in an vegetation, cardiac tissue, or explanted prosthetic valve. The clinical criteria includes two major or one major and three minor, or all the five minor criterias. Possible endocarditis is defined as one major and one minor or three minor criteria. And lack of recurrence of this in spite of antibiotic therapy for less than 4 days or an alternative diagnosis rejects the diagnosis. So in the major microbiologic criteria, it has been divided that microorganisms which are typically causing IE should be isolated in two or more blood cultures, or who are the organisms which rarely cause IE should be isolated in three or more separate blood cultures. Additionally, PCR or nucleic acid based techniques have been added for organisms like Coxella, Bartonella, or Tropharema whipple, and indirect immunofluorescence assays in the form of detection of IgG and IgM antibodies for Bartonella. In imaging modalities, in addition to the echo, we have added cardiac computed tomography, which shows a better, disseminated perivalvular dissemination of the infection in the form of a perforation or a valvular leaflet, aneurysm, or an abscess or pseudoaneurysm. PET helps us wherein abnormal metabolic activity in and around the native or the prosthetic valves, ascending aortic graft or intercardiac device or prosthetic material. Surgical major criteria. Herein, the evidence of IE is documented by direct inspection during surgery, which neither requires a major imaging or a histological microbiological confirmation. The minor criteria, the predisposing factors, additionally include the previous history of IE as well as endovascular intracardiac implantable devices. The other criteria, minor criteria include fever, vascular phenomena, immunologic phenomena, and positive culture PCR and nucleic acid based testing. So, what are the typical IE organisms identified in the blood cultures? Herein, we have additionally added organisms such as Staphylococcus, Enterococcus faecalis, all streptococci except pneumonia and pyogenes. And these are to be considered typical IE organisms in the setting wherein the patient has an intracardiac prosthetic material, wherein Cornybacterium, Serratia, and Pseudomonas should be included. Additionally, the major criteria also includes fastodious pathogens like PCR for Coxella burnetii and IgG immunofluorescence assays for Bartonella. This is what we have discussed. What are the changes in the Duke's criteria? What is the comparative thing in imaging modalities is that cardiac CT helps. This is more sensitive, wherein the infection is disseminated, that is perivalvular spread, to look for abscess, pseudoaneurysm, and fistula. TE is a better modality as compared to cardiac CT in case of vegetation and anything which involves the flow, that is the perforation, paravalvular leak, and regurgitation. PET is specific for confirming IE in cases of cardiac hardware is present, like TAVI or implantable cardiac intravascular devices. There should be an aggressive imaging in cases of suspected cardiovascular implantable device infection. So, if a blood culture is positive with staph aureus or cons, it should be warranted mandatory to go in with an imaging modality with the help of a transthoracic echo or a transesophageal echo, to which helps us to proceed further in the management of such infections. When the blood culture is positive, not in blood culture negative isolated pocket infections, these imaging modalities are required. So FDG, PET, and CT is useful when the diagnosis is ambiguous in such cases. Coming to the poetry study, wherein there is a clinical implementation of early or partial switching from intravenous antibiotics to oral antibiotics in case of treatment of infective endocarditis. Herein, the treatment prevalence and the outcomes of oral step-down antibiotic therapy, especially in cases of left-sided IE, after clinical implementation of the findings, the poetry trial are poorly known. So close to half of the possible candidates of IE received oral step-down, and it was observed that there is non-statistical significant difference between towards the lower incidence of the primary outcome, that is embolic events, cardiac surgeries, or relapse of bacteremia, lower incidence of all-cause mortality, and reduced length of stay among patients who received early oral step-down antibiotic therapy. So here, early switching from IV to oral antibiotics requires certain stabilization criteria in the form that either the patient has received a minimum of 10 days of IV antibiotics or a minimum of 7 days post heart valve surgery. Should be fever free for more than 2 days, leukocytosis counts less than 15,000, CRP less than 20, or at least 25% decrease from the peak value. Uh, and it should be confirmed with a TE to assess the stabilization of infection, and there should be no signs of intracardiac abscess formation or newly developed valve abnormalities. However, in certain conditions like BMI more than 40, or in those where we are not able to find culture negative endocarditis, the step down is uh, not very much helpful. So this is a definitive, in cases of definitive in endocarditis, is a flow chart wherein the blood cultures positive with Staph aureus, streptococcal cons, or Enterococcus faecalis, a satisfying response in the form of no fever for more than 2 days, CRP reduction more than 25%, and leukocytosis, that is decrease in cell count less than 15,000. So helps in early switching of from IV antibiotics to oral. Uh, Other indications for continued IV indications, IV antibiotics, we discussed that BMI more than 40, or there is poor gastrointestinal absorption. However, a TE is always trans thoracic echo is always mandatory to before switching from IV to oral. Summarizing this topic, not everyone needs 6 weeks of treatment, and early oral transition at least 7 to 10 days after IV. What are the guidelines and how is the approach? What are the new changes in the new Duke's criteria? And strong role of the imaging modalities in the form of cardiac CT and PET scan, and the cardiac implantable device infections are missed in 20%, which requires an aggressive approach to screen and so that we don't miss out on those infections.
Right. Thanks, Omkar. Thanks, Omkar, for this in first part of the your talk. So I think to the panelists, may I have four questions. One is, what's your comments on the new criteria? Second is about the POET regimen, where transition from IV to oral. Do you have any experience on this? And third is about your diagnostics, which have been included in the new Duke's criteria, especially when we keep dealing with culture negative endocarditis. Has been always becomes a challenge, and the radiological imaging which has been into the picture. And also, one more criteria is that even if you diagnose the endocarditis on a transthoracic echo, if you see a vegetation, a transesophageal echo is a must, irrespective of the transthoracic echo. TE is a must to rule out any perivalvular abscess and all that. So that's one more criteria. So I think these four criteria, maybe one by one, you can take all these four comments. So one first is comments on the new guidelines of these Duke's criteria. Any of you?
I'll begin first, sir.
Yeah, please.
Yeah, so these are new criteria. Duke's criteria came in 2023. They are very welcoming because we had a huge chunk of infective endocarditis patients who used to be culture negative, and we had to give empirical antibiotics. So this new criteria have incorporated the PCR panel into this endocarditis criteria, which is very good because we can now diagnose infections not just by depending on the cultures but on the PCR based results. Secondly, even the criteria which includes imaging is more welcoming because initially we had to just depend on transthoracic or transesophageal echo, but we know that a myocardial suppression PET scan is very useful in diagnosing endocarditis. So using a cardiac CT or a PET CT is very important. With regards to oral antibiotic change, I have had not used this so far, but there is data to suggest that giving initial 10 to 14 days of IV antibiotic and then switching to oral has a non-inferior as compared to complete IV antibiotics. So I would suggest definitely these criteria are welcoming and they are more in tune with the latest guidelines.
Yeah, Shalmali, Neha, and Ashwini, any comments on this?
Yeah, hi. Hi, Dr. Vasan. Thank you so much. And building upon what Dr. Lakshman has mentioned, um, I think in clinical practice, we do face challenges because many a times it's culture negative infective endocarditis. And the problem is because most of these patients have received doses of antibiotics prior, which decreases or sterilize, I mean, the bacteria does not grow. Now, here, I think for analyzing that which is the likely bacteria, again, basics become very, very important. Of course, the new technologies and the advances have to be adapted, but basic, what has been the onset, duration, and progression of symptoms, whether it's a subacute onset or it's a more rapid and aggressive onset, because that will help us in differentiating or guessing which is the likely bacteria. Staph aureus is going to be more aggressive. Enterococcus as well can be, and also associated findings, for example, UTI or a constipation, elderly patients where enterococcus can be a prominent etiology. So I think this can help. Besides this, when we are managing or evaluating the patient, of course, TEE is very, very important, but 2D echo also has a place in the follow-ups, because even if TEE shows, 2D echo can be assessed as a follow-up screening to evaluate the progression or the clinical improvement.
Right. Ashwini and Shalmali, your comments on POIT?
Comment on the device infections, because we are seeing more and more devices, and this been done at the periphery with a good amount of infection control issues, unfortunately, actually. So we do see unusual bugs so many times. So it is really good to see the change in the guideline that they have included all these unusual bugs in the guideline. And the imaging, cardiac CT, I guess these are more helpful in diagnosing device infections. So yes, that is
Shalmali,
what.
your comments on
Definitely,
PET
these
CT?
guidelines are welcome, but there are some things that I would like to highlight. First is the experience of the person who's going to perform the cardiac PET scan, because although people are quite experienced at KDH, I've had experiences where cardiac PET picked up some uptake at the area of the valve and it was a suspected infective endocarditis, although the culture was negative, and it ended up being actually an ANCA positive vasculitis. So just going on the cardiac PET is not adequate. You have to have the culture also, which is positive to fulfill the major criteria, because the minor criteria like fever, high CRP, high ESR is also present in ANCA positive vasculitis. Secondly, sir, with this cardiac PET scan, we had a case recently which was an ASD device, which very rarely gets infected. We picked up that on the cardiac PET. So there are definitely advantages to performing that, but also we need to be sure that the person who's evaluating is experienced in it. So the more we do, I think the more experienced we'll be.
Any experience with POIT? That is the oral regimen in a
No,
short
sir,
time.
I've not
I
shifted to.
haven't had so far.
No,
Couldn't dare
not yet.
switch to oral for staff.
So same with me. So even though it's more theoretical, which is completely new, which was in the new IDE week 2024 at Los Angeles. So there's a lot of strong data on this oral, and they found no, non-inferiority completely to the injectable what has been given. So you can get rid of the PICC lines, central lines, and all that, and switch to oral. But I think we'll have to have our own experience.
Criteria are very well defined. I think we just need to have confidence in those criteria and start practicing to have our own.
Correct. But these are specific for only, I think, 4 or 5 organisms: Enterococcus faecalis, Streptococcus, staph, and all that. So where you have a good oral regimen, and provided that your patient is body mass index is less than 40, and you have a culture proven these specific organisms, you have done a TE to see that there is no, paravalvular, all that. So all these criteria requires to be fulfilled before we go in for this. I think we'll start because of lack of time. We'll move to the next part, and we may have to rush in with the second part because there are third and fourth also. We have four parts. Okay.
Yeah, for us at least, most of the patients will have a BMI less than 40 as compared to the rest.
Correct.
So proceeding further, the second topic for today. So what is new in the approach to treat prosthetic joint infections? So in addition to the traditional culture positive approach, like to approach to culture positive prosthetic joint infection, there have been new diagnostic modalities in the form of 16S ribosomal RNA gene-based Sanger's and next generation sequencing to test for the pre-operative synovial fluid for the periprosthetic joint infection diagnosis. So herein, we have seen the clinical sensitivity, specificity, and positive predictive values for synovial fluid cultures and the targeted genomic metagenomic sequencing based approach. Combining these two modalities, we have seen that the sensitivity is more when the synovial fluid culture as well as and or the metagenomics have been utilized. So this is a study wherein 36 cases of periprosthetic joint infection uh, compared to the 118 non-infectious arthropathy failure cases. We have seen that the synovial fluid culture was positive in 21 cases with the use of Sanger sequencing. In metagenomic assay negatives, you're not able to find staph epidermidis, staph aureus. Uh, and in those which synovial fluid culture was negative, Sanger sequencing helped in finding out 4 cases. And there in 6 cases, the results of the perioperative tissue or the surrogate fluid cultures was not conclusive. So this is a comparison of joint BioFire panel to the 16S ribosomal RNA gene-based targetings. So these are the set of gram-positive bacteria, gram-negative bacteria, as well as yeast, and it also helps us to know the resistance patterns, especially in case of gram-negative bacteria, as well as gram-positive bacteria. So in this panel, these panel doesn't include organisms like Staph epidermidis, Corynebacterium striatum, and Haemophilus parainfluenza. Here we have seen that with the targeted metagenomic sequencing, we are able to have a better diagnostic, we can say, yield with the as compared to the joint infection BioFire panel. So there have been improved diagnosis of the prosthetic joint infection by culturing the periprosthetic tissue specimens in when these tissue specimens are directly poured into the blood culture bottles, wherein we utilize the aerobic and anaerobic agars as well as aerobic and anaerobic blood culture bottles. So new kid on the block is that historically we have seen that a minority of those undergoing two-stage procedures choose not to undergo the second stage, wherein the surgeons have now intentionally approaching a reduced surgical in order to reduce the surgical risk with the second stage completion. Most patients maintain their spacers. And however, we don't know about the functional limitations and long-term durability with this 1.5 stage exchange, wherein those who not appropriate for their, that is debridement antibiotic beading placement with the cement, followed by a second stage implant replacement, where we can use this 1 point stage exchange procedure, wherein after the implant removal, the spacer itself is of the mold of the implant which has been removed. So coming to the prosthetic joint treatment part, targeted to specific organism base. So specifically in cases of staphylococcal infections, 2 to 6 weeks IV antibiotic therapy followed by fluoroquinolone plus rifampicin or either trimethoprim, that is bacterium doxycycline minocycline, can be used. The length of treatment of total duration of antibiotic treatment in cases of total knee replacement, PJIs, is 6 months, and the other joints like shoulder, elbow, ankle, the treatment duration with antibiotics is 3 months. For other organisms other than staph, the treatment duration is 4 to 6 weeks. So here we've seen that the PGI DATIPO trial, where 136 participants were, we compared, and out of which uh, we've seen that, what is the benefit of early uh, switching from IV to oral, similar to the approach in case of infective endocarditis, like the poetry trial. We've seen that the oral antibiotic therapy was non-inferior to the intravenous antibiotic therapy when used during the first weeks for complex orthopedic infections, as assessed by the treatment failure at 1 year. So, however, in case of oral therapy, there are some barriers wherein there is an active infection requiring IV therapy in the form of bacteremia with Staph aureus or endocarditis. Lack of higher bioavailable options like pertaining to the susceptibilities, drug-drug interactions, allergies, and the gastrointestinal concerns like malabsorption, nausea, vomiting with the oral treatments. We have to be cautious in those patients who are obese or culture negative. There is no well study defining the switch from IV to oral options. And in cases of life or limb threatening infections, as well as those with recurrent same site infection with a prior treatment failure history. So, oral therapy, when to switch? Uh, Similar to the poetry trial, herein we should have a source control which should be achieved, and there is no further plan of return to OT. The patient should be clinically stable, should be tolerating the diet, and based on the antimicrobial susceptibility, the oral options are available. Then we can switch. In most cases of OVIVA trial, the switch was within 7 days, and the DATIPO trial, the mean duration of IV therapy was 9 days, and then switching. These are the highly biolevel oral drugs for treatment of prosthetic joint infections. Summarizing this topic, there should be more emphasis on the diagnostic parts apart from the routine cultures in the form of metagenomics, utilization of 16S ribosomal RNA, next generation sequencing, as well as Sanger sequencing. The new kit, that is 1.5 exchange plan for prosthetic treatment of prosthetic joint infections. Early switch to the oral therapy, both for prosthetic joint infections as well as osteomyelitis, and the role of rifampicin, which from this PGI rifampicin trial, which showed that among those 4,000 patients who have at least received one dose of rifampicin, there was the hazards ratio were lower for recurrence during the first 90 days of treatment, as well as between the subsequent 3 to 6 months. There was no statistically significant protective effect was observed beyond 6 months. That is, this study supports the current guideline, which wherein we use rifampicin as an adjunctive treatment for up to 6 months among those patients, those prosthetic joint infections with Staph aureus treated.
So, coming back to the panel, I think how much of you use, because this is a real challenge when you have patients with coming with septic shock and all that in the ICU with implant infections or even osteomyelitis for that matter, or pyogenic arthritis with septicemia in the ICU, and you send the sample and it comes negative and it's frustrating to what medication should be given. So, what about how many of you do metagenomics, Sanger sequencing, or putting the tissue into the blood culture bottles? So that's the first question. It's open to the panel.
So I can comment on the 16S rRNA, sir. We had used that technique when we were in Apollo Chennai. We used to send the sample to Shankar Nethralaya, but a lot of samples used to detect 16S rRNA with some other pathogens which are not clinically correlating. So then we had stopped sending that. With regards to next genome sequencing, I have had some good results, but the sensitivity is very poor. So the chances are it will not pick up an organism, but if it picks up an organism, has a very high specificity. So next genome sequencing, I had a somewhat a 50-50 experience. Metagenomics we have not used so far.
Right. So there's two important pathogens, Staph epidermidis and Corynebacterium strytum, not being included in the joint infection panel makes our life difficult. Still, comments from other panelists.
NGS I haven't used. We do use Filmare panel and the Bactec cultures. Yes, we are using it and the results are good. I know it's really challenging to manage a culture negative prosthetic joint when we know we are tackling with resistant gram negative. So it's very difficult to plan an empirical regime when we have culture negative prosthetic joints. So having a good diagnostic armamentarium is definitely welcome. But I don't have experience about 16SRN.
Shalmali and Neha?
Shalmali, you want to come in first?
Uh,
Okay, go ahead. Go ahead. Yeah, go ahead. Yeah.
So 16S RNA I've not used. NGS, meaning I have not got very good results. Means I've not got anything positive out of it. In fact, one culture actually grew NTM. We had but it was missed by NGS. So that's my experience.
Neha?
Yeah, so I have not used NGS for the prosthetic joint infections and metagenomics either. I have used BGI panel, and it has been useful for the diagnosis of certain infections, especially MRSA, and also negating certain non or helping in establishing certain non-infective etiologies like a psoriatic arthritis. But with BGI panel, I've also had a case where it was Burkholderia pseudomallei, which was missed by the BGI panel, and not just missed, but it also detected streptococcus species and strep pneumoniae, leading to misdiagnosis. So it can result in false positivity with the streptococcus species, which we have to be extremely careful about.
Yeah, right. So I'll tell you my experience. I've been almost subjecting each and every sample which is coming negative from the paravertebral tissue or from the joint infection panel for Sanger sequencing, which has been very, very disappointing to me. But I've been sending for metagenomics, the next generation sequencing, and there also I've got at least a Sanger sequencing, so has been a big failure to me. But next generation sequencing metagenomics has been meaning I would say 50-50% results, which has been able to pick up a lot of organisms. Like recently, I had a patient with post heart transplant, retrosternal collection, and almost everything NGS cultures with pushing it in the blood culture, everything came negative. Even the pneumonia joint infection panel came negative. And I think here the pneumonia panel helped us to pick up the organism. But metagenomics has been useful in 50%, I would say, but I think still it is evolving. Quickly on oral switch for paravertebral abscesses or joint infection panel, because I think we did not discuss about paravertebral abscess because the treatment and the protocol and almost the guidelines are similar to that. So after 7 to 10 days or 2 weeks of therapy, how many of you really switch to oral if the organism has been having an option to switch to oral therapy?
If it is a good surgical control done and we have oral antibiotic available, we'll be comfortable switching to oral after 2 weeks. Not 1 week, definitely. 2 weeks, yes. And that's what we're practicing.
Yeah, I agree with Ashwini. If you know the bug, you know the sensitivity, and source control has been done. After 2 weeks of IV, we switch to oral for 6 to 8 weeks.
Right. Neha and Shalmali?
Switching to oral after 2 weeks if it's a sensitive bug.
I think the certain Neha, your comments. I think switching to oral, especially drugs like cephalexin or even your levonorofluxacin, all these have excellent Bactrim, clindamycin, all these they have really good penetration in the bone. And I think we can easily switch after 2 weeks of parenteral therapy to oral. And they have found this both in the DETIPO trial and the OVIVA trial that it's non-inferior and good results. So I think this gives us a lot of confidence. I think we'll move to the third part, and that is, I think, Omkar is going to speak about.
So today's third topic is what is new in vaccines. Herein we will see the recombinant influenza vaccine, the high dose flu vaccine, and the comparison of results with high dose versus a double dose influenza vaccine in case of renal transplant, RSV vaccines in infants and adults, and role of nirsevimab in RSV LRTS. So the recombinant or standard dose influenza vaccine in adults under 65 years old, the quadrivalent recombinant influenza vaccine contains 3 times the amount of hemagglutinin as compared to the standard dose egg-based vaccine. The results show that the high dose recombinant vaccine conferred more protection in the PCR confirmed influenza cases as compared to the standard dose vaccines among adults in the age group of 50 to 64 years. Thus, that the high dose recombinant influenza vaccine was more effective compared to the standard dose in PCR confirmed influenza cases. So these are the results. Coming to the next vaccine, that is Fluzone, that is high dose seasonal influenza vaccine, contains 4 times the antigen as compared to the standard dose flu vaccines. It has been approved for people 65 years and older and recommended as an acceptable option for the flu vaccinations in the age group of 18 to 64 who have had a solid organ transplant or are taking immunosuppressive medications. The criteria being that is more antigen, more benefit. We can see the relative vaccine efficacy against influenza, wherein the flu high dose vaccines had fewer influenza cases. The side effects are more or less similar in both the cases, both the vaccines. These are again the relative vaccine efficacies comparing the Fluzone versus the standard dose. Role of double dose quadrivalent inactivated influenza vaccines in adult kidney transplant recipients. The American Society for Transplantation has recommended a high dose or a booster dosing in the same season, which is through which we can the greater immunogenicity can be achieved as compared to a single standard dose. These are the seroconversion with the comparative results with quadrivalent double dose group. So the next topic.
95%.
So with the high dose recombinant vaccines, 95% seroconversion. The efficacy with the high dose is more than 95%. But you can see the third vaccine will be the RSV related LRTI, and how can we try to prevent it. So these are all the vaccine products licensed and available by the FDA. 2 products are recommended by the ACIP to protect the infants and young children from the RSV related LRTIs. That is RSV prevention in infants during the first RSV season. That is those less than 8 months and have not their mothers have not been vaccinated. Either we give maternal vaccinations between the 32 to 36 weeks of gestation, or use nirsevimab in those who have not received and age less than 8 months. For children in the age group of 8 to 19 months and at an increased risk of RSV disease entering into the second RSV season, we recommend an additional dose of nirsevimab. What is the timing of immunization? That is, in maternal RSV vaccines, vaccination should be done anywhere between 32 to 36 weeks of gestation, using the seasonal administration, meaning that between September and January in most cases. Nirsevimab is basically the optimal timing, that is just shortly before the RSV season and continued during the season. For infants who are born or before or during the RSV season, it is advised to immunize them within first week of birth or during the same birth hospitalization. The indications of nirsevimab, that is neonates and infants and children less than 24 months of age. Recommendations are for infants shortly born before, as we discussed, immunize within 1 week or the same hospitalization. And recommendations in cases of subsequent pregnancies for people who have received previously vaccines in the previous pregnancy are not recommended to receive an additional dose. And infants born to people who are previously vaccinated should only receive nirsevimab. Recommendations, however, can be updated. So ACIP recommends RSV vaccines for adults more than 75 years of age, as well as the age group between 60 to 74 years, that is all the diabetic and COPD population, those with cardiovascular diseases, and more than 75 years of age. CDC recommends vaccinations to all age adults with age more than 75 and in between 60 to 74 with an increased risk with the underlying comorbidities should get a RSV vaccine. So key takeaway points is the all infants should be protected either by a maternal RSV vaccine approach or by nirsevimab. Both need not be given. Pregnant, in case of pregnant person, the timing is between 30 to 36 weeks of gestation, and infants less than 8 months whose mother have not received, and those between 8 to 19 months and at an increased risk factor should receive nirsevimab. And an RSV vaccine for adults, that is more than 75 years, and in the age population of 60 to 74 years with comorbidities. So coming to the last topic, what is new in CMV treatment approach, that is monitoring. So this is what a CMV syndrome and gastrointestinal disease and the domain. So CMV specific cell mediated immunity assay guided prevention. So it is promising but not very much ready for prime time. So the donor and recipient CMV IgG is the only risk stratification test routinely performed. It is based on the principle that the seronegative recipients receiving seropositive graft are at higher risk, whereas those who are seropositive are at intermediate risk. However, the risk of post-transplantation CMV is more complex than just the CMV seropositive sero status. Herein comes the cell-mediated immunity against CMV. That is, these are the CD4 as well as CD8 T lymphocytes, predominantly conferring the protection against the CMV disease. Several new assays assessing this specific CMV cell-mediated immunity using the stimulant to trigger these immune cells have been developed to improve the tailored strategies for treatment and prevention of CMV in cases of solid organ transplants. These monitoring has been an emerging tool that has evaluated variable results. That is, prior to transplantation, it helps to predict the risk of CMV infection post-transplant, to determine the optimal duration with the antiviral prophylaxis and monitoring the viremia, to decide on antiviral therapy in cases of asymptomatic patients with the replication ongoing, to determine whether the need of secondary prophylaxis, or to predict risk of CMV recurrence after completion of treatment. And in general, the high CMV specific cell-mediated immunity predicts that there is protection against the CMV evolution, whereas the low CMV specific cell-mediated immunity, those are at an increased likelihood of CMV replication. Patients with an indeterminate results suggest a deeply annulled immunity. So these are the commercially available assays. This is a theoretical model of a quantiferon CMV response, wherein a robust response of interferon indicates a decreased risk of CMV, that is a high CMV specific cell mediated immunity, and a minimal interferon gamma response indicates a low CMV specific cell mediated immunity. These are the incidence of subsequent CMV disease in non-reactive and the reactive populations. This is the quantiferon CMV reactive and the non-reactive cases application. So herein, those individuals who have received ATG and CMV seropositive, they should be started immediately with antiviral prophylaxis post transplant, and their cell mediated immunity specific to CMV should be checked at 4 to 6 weeks. If it is high, then we stop the prophylaxis and stop the monitoring. And when it's low, we continue the prophylaxis. And in those individuals who have not received ATG, we use a preemptive approach. That is, post transplantation, we do the cell specific, CMV specific like cell mediated immunity assay. And if it is positive, no response, no treatment required. And if it's negative, we continue with the preemptive approach. Thank you.
Yeah, just coming from the analyst about using double dose of influenza vaccine for specifically cardiac, respiratory. Do you use it in 2 doses? Of course, high dose. This was just to update what is new happening in the world. Just to update all of us. These are the newer vaccines which are RSV vaccine or even for more than 75 years of age, and high dose flu vaccines which are available, which is 4 times the dose available abroad, and not only abroad but also available in Thailand, Bangkok, close by. So I just wanted to just 1 or 2 answers from the panelists. Whether you use double dose?
In India. So there is a lot happening in the Western world. We have pneumococcal 20, we have high dose flu, we have RSV, everything, but none of it is there in the Indian market yet. This intradermal flu vaccine, high dose flu vaccine, everything has been studied since long. It's been recommended since long, but we don't have it available here. So
do you use it twice, like in some patients with,
flu? I haven't used twice. No, still using single dose even for transplant.
Okay. What about Neha and Lakshman and Shalini?
No, sir, we have not used this double dose vaccine even for a higher risk population like diabetic, cardiac, or transplant. We still have used only a single dose of flu vaccine.
Okay, I do use in some high risk patients 2 doses per year, that is April and September, in those who are extremely at high risk, elderly, structural lung disease, and all that, or some patients with severe CKD, diabetes, elderly patients, where the efficacy of the vaccine may be low. So I think, and about the CMV diagnostic, just like TB Gold, we have the CMV quantiferon Gold, which is there, which if it is positive, tells you a robust CMV immunity for the patient rather than IgG CMV, which is just tells you that the patient is at intermediate risk. Those patients who are going in for transplant and getting into the ICU subsequently, if your IgG only is positive, it is intermediate risk. But if your CMV cell-mediated immunity is strongly positive, it tells you possibly you may not require follow-up doing the CMV viral load in preemptive. And if your patients are on valganciclovir, you may, or IV ganciclovir, you can discontinue the treatment after if your CMV cell-mediated immunity is strongly positive. So that is what it shows. I think that's all from ID point of view. What was new in ID in 2024? I'll tell Arindam to take over the proceedings.
Yeah, good evening, everyone. Dr. Pritima here. I'm extremely sorry for my voice, but Dr. Arindam is little stuck up with the one patient. So thank you so much, Dr. Vasan, for a wonderful session. Dr. Neha Gupta, Dr. Shalmali, Dr. Imran, Dr. Lakshman. Everyone has given a very wonderful experience in infectious disease, and this was very fruitful for everyone. Thank you so much. Now moving on to next session, I would like to invite Dr. Polemy, who is a very good friend of mine. She is the specialist in National Tuberculosis Center, New Delhi, and she has almost 16 years of experience in pulmonology. We worked together in Medanta, and I have seen her work and her interest in her subject. So, Dr. Polemy, I think today's session is on pulmonology critical care. So, Dr. Polemy will moderate this session And I will like to invite Dr. Rajiv Jain, sorry. He is a consultant pulmonary medicine in HN Reliance Hospital. And he is going to present 3 or 4 articles, which is common in pulmonology and critical care. And Dr. Polami will moderate the session. Dr. Polami, are you there?
Yeah. Good evening, everyone. Thanks for the wonderful introduction, Pritima. So we'll just start with the 3 articles that we have chosen, which is very relevant to our everyday critical care and pulmonology practice. Dr. Rajiv will be presenting, and then we will be approaching the panelists for their inputs. Dr. Rajiv, are you there?
Yeah. Yeah. Hi.
Hello.
Yeah. Good evening. I'll just start my presentation. Hi. Good evening, everyone. So today's critical care update, Pulmo Critical Care. So there are 3 articles that we will be discussing today. One is a focused guideline, another is a meta-analysis, and a third one is a RCT. So I'll start with the first guideline. So this is the 2024 focused update. Is a guidelines on the use of corticosteroid in sepsis, acute respiratory distress syndrome, and community acquired pneumonia. So basically, they are updates on the 2017 guideline by the Society of Critical Care Medicine. They were published last year. So the first topic among them was corticosteroid in sepsis and septic shock. So the recommendation was they suggest administering corticosteroids in adult patients with septic shock. It was a conditional recommendation with low certainty of evidence, and recommend against administration of a high dose short duration. So a corticosteroid of anything more than 400 mg per day of hydrocortisone equivalent for less than 3 days in adult patients with septic shock. This is a strong recommendation and moderate certainty of evidence. So they found that steroid in septic shock, it may reduce hospital or long-term mortality and probably reduces ICU short-term mortality, but may increase neuromuscular weakness, probably increase hypernatremia and hyperglycemia. It also reduces neuropsychiatric effects among the patients, but there is an uncertain effect on GI bleed, superinfection, stroke, and myocardial infarction. So a total of 46 RCTs were examined by the panel, and this was the conclusion they had come up with. So the main difference was in the 2017 update, they had recommended for it to be used in patients of only on moderate to high vasopressor doses, but now they have recommended for all patients of septic shock steroids. So this was the main difference, that evidence shows benefits of corticosteroids in septic shock with requiring vasopressors regardless of the dose of the vasopressors. And the next was corticosteroids in acute respiratory distress syndrome. So this suggests administering corticosteroids in adult critically ill patients with ARDS. So this the steroid probably reduces the 28-day mortality. A longer course of corticosteroid that's more than 7 days that has a higher survival rate as compared to those who receive shorter corticosteroids at 7 days or less. It also may lead to fewer days of mechanical ventilation or shorter hospital stay, but uncertain effect on ICU length of stay, neuromuscular weakness, and GI bleed. So the earlier panel, the earlier 2017, they had told that steroids should be used in ARDS patients with the PF ratio of less than 200. But here, after discussion and after the new evidence, mainly evidence was the COVID evidence when COVID ARDS, when steroids were used. They added that, and then they have removed the qualifier for PF ratio. And they have also, in the updated analysis, they have not been able to differentiate any corticosteroid timing, any advantages of any particular corticosteroid when it has to be given, or any type of corticosteroid. And so since there were no subgroup effects, the specific recommendation was not made for which corticosteroid molecule to use, any methylprednisolone or any other molecule. And lastly was corticosteroid in community-acquired pneumonia. So there were two recommendations here that we recommend administering corticosteroid in adult patients hospitalized with severe bacterial cap, but they made no recommendations for administering corticosteroids for adult patients hospitalized with less severe bacterial cap. So in most severe cap, it probably reduce hospital mortality, an effect which is not seen in less severe cap. Corticosteroid probably reduce the need for invasive mechanical ventilation and also may decrease the duration of ICU and hospital stay, but probably increase the risk of hyperglycemia, may increase secondary infections, but uncertain effects on GI bleed. So this was the criteria for severe community-acquired pneumonia. So we have the ATS IDSA 2007 criteria, which use either one major or three minor criteria. So the major criteria being sepsis requiring vasopressor, respiratory failure, and minor criteria RR of more than 30, PF ratio less than 250, multilobar infiltrates, confusion, uremia, leukopenia, thrombocytopenia, hypothermia, hypotension. And the other criteria that used was the Cape Cod. The Cape Cod was a big RCT which came out last year for community-acquired pneumonia, which were actually almost 35% of the patients used in this analysis were had severe cap. So their criteria was initiation of mechanical ventilation with positive at least PEEP of 5, administration of oxygen to HFNO with a PF ratio of less than 300 and FiO2 of more than 50%, NRBM with estimated PF ratio of less than 300, or a pulmonary severity index score, which more than 130. It's a big score. There are multiple parameters which you can input and you get a value. So anything above more than 130 is a group 5. So any one of them is a severe cap. And you also have other risk stratification scores. So the pneumonitis severity score of 4 or 5, or you have the CUB 65, that's confusion, urea, nitrogen, respiratory rate, blood pressure, age more than 65, score of more than 3, confusion, oxygenation, respiratory rate, and blood pressure of more than equal to 2, or systolic blood pressure, multilobar, chest radiography, albumin, RR, tachycardia, confusion, oxygenation, or arterial pH, any more than equal to 3. So any of these criteria fit into severe cap. And these were the common corticosteroid regimens. So here in this guideline, they have not recommended any particular corticosteroid regimen. So these are just the regimens that they have stated have been used in multiple RCTs throughout the years for the particular for septic shock, ARDS, and severe cap. So hydrocort, the commonly used is hydrocortisone 200 mg per day, a continuous infusion, or you can divide it into 6-hourly dosage, with or without a fluorocortisone 50 mics enterally for 7 days or until ICU discharge. So for ARDS, was early ARDS within 24 hours. So Dexa, you give 20 mg followed by 10 mg Dexa. Or an early ARDS, it's within 72 hours, you give a methylprednisolone 1 mg per kg followed by gradual taper for almost 28 days. And unresolving, that's after 7 days. So you start at a higher dose, 2 mg per kg, and then gradually taper it for up to 32 days. So severe cap, multiple steroid courses have been used. So you have hydrocort 200 mg once, then 10 mg per hour infusion, or a 200 mg daily divided for 4 or 8 days, depending on clinical improvement, followed by a taper, or a methylpred 0.5 mg per kg for twice a day for 7 days, or methylprednisolone 40 mg bolus and then gradual taper over 20 days. It can be administered either continuous infusion or can be divided as twice. So, thank you. We'll go for the second, or
I think we'll discuss the first topic and then we'll go to the second one.
Yes.
So I would like to welcome my panel consisting of Dr. Nimish Shah. He's a practicing consultant, pulmonary and sleep medicine at Sir HN Reliance Foundation Hospital and Research Center. And he has a rich experience spanning of more than 11 years from various reputed national and international institutions. I would also like to welcome Dr. Rajesh R. Sharma, mentor and consultant with a rich experience of more than 30 years in the field of pulmonary medicine and enriching HN Reliance Foundation Hospital and Research Center. And he's a specialist in pulmonary medicine and intensive care with a wealth of knowledge and experience and having been in the practice since more than 30 years. Welcome, sirs. So we'll go with the first discussion, as in the dosage and the usage of corticosteroids in conditions like sepsis with septic shock, ARDS, and severe CAP, as has been lucidly described by Dr. Rajiv Jain. So I would like to ask the panel on their comment on the dosage and duration and your like your individual experience in patients with sepsis, with septic shock, or ARDS and severe CAP.
Follow me. Nimish is busy with one patient. He's joining in 5 minutes. I think you can pass on the question to Dr. Rajesh as well.
Okay,
Yeah,
I would ask.
I would be happy to answer this question. For so many years that I've been in practice, somewhere or the other, we have administered steroids. 30 years back, I've given steroids. I've given steroids often even now. But I'm glad there is at least a study which then defines it, because when we did it, it was very erratic. The doses were erratic. It was your experience, my experience. It was individual experiences which guided us. And we tended to sometimes err on giving a higher dose of steroids. But with these studies, things become more defined. It makes things much more easier. At least it gives you an idea what dose of steroids are safe. And also it clarifies. See, I'm very glad this analysis has brought into limelight so many factors, because in the ICU, when with the multidisciplinary team, with patient who is septic and has complications, when a consultant decides to give steroids, it's common experience that if he gets a GI bleed, you are blaming the steroids for it. At least from what has been documented in this analysis, the risk of GI bleed seems to be very low, at least. So is the when you come to a patient and you say, oh, he's in sepsis, let's give steroids, and then you say, oh, he'll develop critical illness neuropathy. It seems that the evidence doesn't favor that. At least the risk seems to be very low. So at least I think that's a good thing to bring out, because even the risk of infections is, though it is increased, it is not, there is low evidence to suggest that it causes something which can go beyond. Yes, but possibly that maybe because if you tend to give a higher dose of steroid might be detrimental. So giving a guideline which says the appropriate dose of steroid and the duration is a good thing to take home, and I am sure most of us have given steroids without, before this article came out, we've been giving empirically. But this is like a stamp on what we have been doing.
What about your experience? There are certain gray zones, as in patients who have developed ARDS post-surgery. What is your experience? And patients with already neurological side effects with ARDS. So what is your take on those specific patient subgroups and institution of steroids in such a patient subgroup?
See, I'll tell you, normally what happens is that when you have a patient with ARDS, now obviously when a patient is septic, if the patient is septic with vasopressors, as per this thing, you are supposed to give steroid, low dose steroid, in all patients with septic shock, irrespective of vasopressors, whether they have ARDS or otherwise. Of course, the dose is to be on the lower side. Now, when you talk about ARDS, per se, they have said that in early ARDS, you should give steroid, and if it is resistant. The question here is that we always were, the question comes that when you are dealing with a post-infective situation where you have an uncontrolled situation, an uncontrolled infection, maybe along with fungal infection, superadded fungal, that's when you are extremely worried about giving steroids, especially to reverse a situation, because you expect that it is likely to worsen. This meta-analysis has not differentiated between the reasons for the ARDS. It has not mentioned whether it is post-surgical. They have just said ARDS, whether it is in a particular subgroup or whether it is tropical illness related. It has not specified. Probably they don't see tropical illnesses that the way we see. We've been seeing dengue, hemorrhagic fevers. We've been seeing malaria-related ARDS, in which often all of us have given steroids. The only question here is that we have given higher dose of steroid in people with dengue, hemorrhagic fever with ARDS rather than a lower dose. Now, there is no specific study which has been done because this study has come from abroad. We have our own set of problems. If you ask me, I'm not very sure about this answer. That the question that you say, I'm not very sure whether how safe it is to give a steroid with ARDS post surgical sepsis. But I think if there is septic shock, we still would give steroids, a small dose.
Yes.
But
Maybe
just
without septic shock, we'll wait, but with septic shock, maybe.
Possibly. I have a little different take. I always believe steroids are safe provided they're adequately controlled with the appropriate antibiotic. So if you have cultures and you are able to give the appropriate antibiotic and you're sure that your antibiotics are right, then maybe steroids with its anti-inflammatory and properties might be safe given in the right doses. May not be so harmful as what we expect it to be.
So I think these certain gray zones will need more research, like as in like surgical sepsis with shock, patient with neurological side effects, and
because none of these articles, so though they are talking about GI bleeding and all, nobody talks about wound healing, because post-surgically are also worried about wound healing, and steroids are known to affect wound healing. But I think when you are dealing with a patient who is going to die, your priority is to save the patient first. Wound healing would come later, So I think the decisions change as per the patient that you are seeing.
Condition and the clinical.
So, sorry for the interruption. Polmy, I would like to introduce Dr. Paras Jain. He is Additional Director of Critical Care Department, HN Reliance Hospital. I think Dr. Pandit will not be able to join, so we can include Dr. Paras as a panelist.
Welcome, Dr. Paras. Good evening.
But your question, this is my opinion, but I would be happy if there is some difference of opinion contrary to what I have said, if somebody has a different take on what I have said.
Dr. Paras, would you like to add on something? So we were discussing on the role, the dose, the duration of corticosteroids in sepsis with septic shock, ARDS, and severe CAP. So we would want you to share your experience in the usage of steroids in conditions like post-surgery sepsis with septic shock or without septic shock, or patients with ARDS with neurological presentations. So what is your take on this topic, sir?
No, I agree with what Dr. Sharma mentioned. I think over last 2 decades, I think steroid story had changed from giving a very high dosages of methylpred in late 90s to after ANAND trial in septic shock, starting with the Hydrocort 56 hourly or continuous infusion of 200 milligrams. And then again, after Corticus and adrenal trial, again, people were against using steroids. But I think most of the meta-analysis are in favor of using hydrocortisone load 200 milligrams in a septic shock associated with the reduction in vasopressor use and survival benefit. In a pneumonia French trial and other small trial showed benefit and potentially that was, even though it is a significant, it is still a risk versus benefit we have to look for. And in a severe form of pneumonia, I still use, and there is a reasonable evidence in favor of using 56 hourly hydrocortisone in patients with severe community-acquired pneumonia. ARDS, again, it is a changing story. After ANAND trial, we use that the algorithm which was showed methylprednisone taper over 5 weeks period of time, and then recovery trial showed 6 milligram of dexamethasone, while Lancet Respiratory Medicine publication recommended 20 milligrams. That trial showed a significant benefit. Again, we don't know what to use. Definitely, we have to look for risk benefit. As long as there is a good source control in surgical patient and appropriate antibiotics, then potentially, if patient is already on a very high oxygenation or shock state, definitely I think use of steroid risk benefit, taking a risk for any fungemia or any superadded bacterial infection. Again, as Dr. Sharma said, risk versus benefit of a survival versus or dealing with the problem at later date. That is always there. But yes, we don't know how much risk is involved. Definitely we see hyperglycemia. Definitely we see some patients with a critical illness, weakness post giving higher dosages of prolonged steroids. And wound healing is always a problem. But I think risk versus benefit, we have to weigh before making that decision. Yeah.
Okay, sir. So I think we would move on to
just one comment. I think many of these trials, some trials have used dexamethasone, some have tried hydrocortisone. I think many of these are also the choice of steroid also has in these trials have been based on what is cheaper, because methylprednisolone definitely is more expensive than dexamethasone or hydrocortisone, I believe. In India, we tend to use a lot of other, very easily. But I think many of the trials, the choices of the steroid might also have been dependent on the cost of the steroid that you are using. But hydrocortisone, again, when you look at this trial and you say that hydrocortisone combined with fludrocortisone might be superior when you're dealing with septic shock, you tend to believe that, which choice of steroid, maybe I would try to give one which has a better mineralocorticoid activity. So if I'm dealing, if I have to logically think, correct me if I'm wrong, of course, this article clearly mentions that they are not able to choose between the types of steroids, and they have said you don't give high doses, but they are not specifying that prefer one over the other. But my thing, if you ask me, I have a little, maybe more studies need to be done. But if you're dealing with a situation where you need steroid with a better mineralocorticoid activity, then like in septic shock, it might be better to have some steroid with more mineralocorticoid activity. I might preferably use, hydrocortisone, dexamethasone, maybe add fludrocortisone. While if methylprednisolone seems to have more glucocorticoid than mineralocorticoid activity, I might, if I am dealing with communicable acquired pneumonia, where I want more of anti-inflammatory rather than, and who is not in shock, maybe if who is not in shock, I might just wonder whether it is better to give, methylprednisolone, which has more affinity for the lung, as more potent, for the lung. Of course, I am not saying that it is just a thought process. Maybe, so we could work on that and, have something which gives us some idea. I don't know what Dr. Paras has to say on this.
No, agree. I think from a basic science point of view, that makes sense. But I I usually either use hydrocort or dexamethasone. Methylpred I previously used when I was doing respiratory medicine, but I haven't used methylpred for a long time, other than pulse dosages of methylpred in vasculitis or some other conditions. Yeah.
So thanks for the excellent input, Dr. Sharma and Dr. Jain. Definitely, there will be food for thought regarding maybe for future research purposes, like type of steroids to be used in specific conditions and the dosage and the duration. And definitely, we have already established the fact that steroids are definitely lifesavers in such conditions. Now, the more food for thought is which types of steroids and what are the duration and dose. And definitely, at the moment, it's all relating to the patient condition at that time and our clinical experience and past experience. So I would conclude this topic, and then I will request Dr. Jain to move on to the next topic.
Just share my screen. Yeah. So this is the second article for today. So this is a systemic review and meta-analysis, which was published in BMC Pulmonary Medicine last month. So the topic was effects of pulmonary rehabilitation respiratory function in mechanically ventilated patient, a systematic review and meta-analysis. So the aim of the study, the aim of the systematic review and analysis was to explore the effects of different types of pulmonary rehab on respiratory functions in mechanical ventilated patients, and also to determine which is the optimal type of intervention. So total they identified around, so based on web search, around 1920 of the study. So after multiple duplicates removal, they screened around 314. And based on title and abstract, 276 were excluded. So finally, then 38 were eligible, out of which the population did not match and the outcome did not match in 26 studies. So finally, they included 12 studies in the systemic review, and out of this 12, the 10 were included for the meta-analyses. So the primary outcome they included was MIP, MEP, that's maximum inspiratory pressure and maximum expiratory pressure, the RSBI and the tidal volume. The MIP and MEP was chosen because the MIP and MEP, they represent the respiratory muscle strength quite well. And RSBI is very well known as a weaning criteria. So that is why RSBI was chosen. And tidal volume is quite easy to see, and definitely it depends on the respiratory muscle strength also. So that's why these 4 criteria were included. So 10 studies measured MIP, which the sample size was 216 in the intervention and 218 in the control. 5 studies measured MEP, where sample size was 115 and in the intervention, 112 in control. RSBI 4 studies measured with sample size of 96 versus 98, and tidal volume 4 studies, again a sample size of 96 versus 98. So these were the detailed summaries of the RCT that were included. So majority of the studies were either Brazil or China, with 1 study in Egypt. So, and these studies, they either have IMT, that's inspiratory muscle training, the pulmonary rehab type, or IMT with the extremity muscle training, or NEMS, that's neuromuscular electrical stimulation. 1 study also did a abdominal sandbag training, and rest again was a combination of MES and IMT. And with the so the intervention did vary, like twice a day, or you have 4 to 6 sessions a week, or 5 times a week, or so it little vary, but mainly they were twice a day or once a day sessions which were done, and they were mainly done in ICU setups. So 2 were then respiratory critical care setups, 1 in surgical ICU, 1 in neurosurgical department, and another in surgical department. And duration of mechanical ventilation was minimum of 48 hours, and 1 study even took up to 63 days. So this was the forest plots of the final analysis that they did. So with the mean difference for MIP, MEP, RSBI, and tidal volume. So MIP and MEP both showed that pulmonary rehab, like an IMT or an NMES done, shows an improvement in the MIP and MEP. But if the same effect was not actually seen for RSBI, because they found that this IMT or using NEMS, there was not much change in the respiratory rate. So the RSBI did not improve much. And but it did improve the tidal volume also, the MIP and the MEP. So this systematic meta-analysis highlighted the benefit of respiratory function mechanical ventilation, which could significantly improve the MIP, MEP, VT, diaphragmatic thickness, as well as diaphragmatic motion. But there was little difference between the RSBI and a very uncertain evidence on respiratory rate. The measures, they were also more effective when you have more than 48 hours a patient has been mechanically ventilated in the ICU. So compared to other outcomes, these outcomes, the MIP, MEP, the tidal volume RSA, they're directly visible indicators. So they clearly reflect the change of respiratory function. So it can increase the awareness of the ICU team and the acceptance of pulmonary rehab. And the methods such as the IMT or the NMES, they significantly improve the above-mentioned indices so as to enhance the respiratory level muscle and accelerate the time of weaning and also improve patients' quality of life. The PR was evenly beneficial for respiratory function, which include a shorter ventilated duration, but it remains still unknown, but which is the best intervention amongst all these various protocols. So IMT improved MIP and MIP, but no significant effect on RSBI tidal volume, which one they hypothesize that IMT is probably difficult to monitor and control to meet the rigorous criteria. So, and another this meta-analysis also showed that NMES appeared more like straightforward and safe modality for the critically ill. And when combined with physical therapy, it significantly improves the extubation success rate and shows a better ranking over physiotherapy or NMES alone. So results also show that NES had influence on MEP, statistically significant different to MIP only when it is combined with IMT. Therefore, NMES combined with other training strategy, so maybe a superior rehabilitation strategy. So one study that was on the abdominal sandbag training. So they showed that it had a remarkable effect on the outcome, but it's a very small study, the sample size. So there was could not be support as an evidence. So the further confirmation needed for that. And it tended to improve respiratory function regardless of the intervention duration. So even like if you do for 7 days, less than 7 days, or shorter period, or more than 7 days, so there was not much difference. But more research is required to prove that what is the optimal duration of intervention. But limitation of these meta-analysis were the only 10 studies, which total were 504 individuals eligible for this meta-analysis. So a small size and publication bias is there. And among the included article with low to moderate evidence, the major risk of bias was lack of blinding and deviations from the intended intervention. So you need a higher quality RCTs with a larger sample size. Considering the diversity of different respiratory related outcome indicators, and small number of inclusive studies, only the studies reporting MIP, MEP, RSB, and VT were included in this meta-analysis to ensure there's reliability of the study and some comparison. Analysis of moderator effects on the pulmonary rehab programs at age, sample size, sex, comorbidity, sedation level were not performed. Meanwhile, there were lack of reporting on adverse events. Lesser clinical therapeutic effects could be identified for the treatment plan. Although they use random effect model for pooling, the high heterogeneity of the intervention as well as duration might not be neglected and should be considered in clinical practice. And the exclusion of non-English studies, which may have some selection bias here. So finally, they show that there is a mixed effect on significantly improving the respiratory variables, but the rehab, when pulmonary rehab, when used in IMT, the inspiratory muscle train could administer the best therapeutic effect followed by neuromuscular electrical stimulation. Thank you.
Thank you, Dr. Rajiv, for your very lucid and very nice presentation. Because after reading the article, even at the end, I was also confused with the conclusion. So you presented really well. So I would like to ask Dr. Sharma and Dr. Jain on your experience in your setup regarding pulmonary rehab in critically ill and mechanically ventilated patients.
If you see, it is quite well documented that patient on ventilator has to have some sort of physiotherapy, has to be given, whether it is chest physiotherapy is a must on non-ventilated patients. One is to prevent complications and to improve the work of breathing. Okay, so question is, it becomes quite challenging because critically ill patients who are unstable on ventilator, managing physiotherapy is not a simple thing and it's not very easy. If you have a good setup, then you need the dedicated physiotherapist who can spend time doing all this. But this article, at least the purpose of this article, when you see it, it is when people are on ventilator, it is presumed that longer duration of ventilation is associated with muscle wasting, and respiratory muscle wasting would occur, and that would further delay weaning off ventilator. And that was the purpose why you want to do something that will help improve the respiratory muscle strength so that weaning is possible. It seems this is how the purpose of this trial, and that is why MIT or IMT or neuromuscular stimulation has been to stimulate the respiratory muscles. Now, from my teaching, that age-old teaching, we all know there are two types of muscles. One is the white muscle and one is the red muscle, skeletal muscle. While your intercostal, your accessory muscles are known to be red muscles, your diaphragm is a white muscle. So when you walk or run, you get tired, you sit, but you breathe throughout your life and you don't stop breathing. But when the white muscle fatigues, it takes longer to recover. So when a diaphragm is fatigued, it's going to take time to recover. So if you have a tired muscle, whether a stimulation to loading the muscle in trying to help it recover, whether it is the right way to go about it, I'm not very sure. But from this article, whatever they are showing is whatever they did, diaphragm stimulation, neuromuscular stimulation, loading the diaphragm, it does seem to improve the respiratory muscle effort and improve the MITs so that the patient can get better strength in to breathe and help in weaning off. So it does look promising, but I think physiotherapist with knowledge on this would be better be able to highlight from his experience. The other thing is that when you go through this article, the way they have tried IMTs, there are two ways. They have it's like a dynamic. You have a loading situation where you might. It's like if I have to think, even on a ventilator, if you want to check for the inspiratory muscle strength, peak inspiratory effort, you might just increase the trigger, make it more difficult for the patient to initiate a breath, and that will tell you your inspiratory muscle strength. So if you do that, that is the load that you're putting, because once the ventilator, you trigger the ventilator, then that load goes away, because then the ventilator kicks in the breath and it will give the breath. Okay, so it's the initial loading. On the other hand, you think of a patient who has a narrowed endotracheal tube, where he will have to continuously create an inspiratory effort to continue to breathe throughout the inspiratory cycle. You understand? So there would be two ways you can create a load on the inspiratory muscles. One is a continuous way, where he has to continue to apply effort in order to take the whole breath throughout the inspiratory cycle, and the other is only during the initiation of the breath. Okay, now which is more effective? Well, I think the article does mention that they found better effect when it was the loading technique which they used. But when you read this article, so when you see this, they have also specified, I'm glad, because they also understand that this is not something that they are very specific, that it has to be done twice a day and it has to be intermittent. It is not done continuously. So you are using this technique so that you don't overtire the muscles also, because in a patient who's sick, you don't want to overtire the muscles. So what I mentioned about diaphragm fatigue takes longer to. So when somebody does this, has to be very clear that it is intermittent and it has to be done in a specified way. Maybe short periods to just stimulate the respiratory muscles. I would like Dr. Paras to
Dr. Paras, your take on it.
So, firstly, I think from a basic science point of view, as Dr. Sharma mentioned, that makes sense. I think a big question is whether it improves the outcome or whether we are able to make patient ventilator free early. And all these small single center trial looks like have shown definitely some benefit. I don't have personally experience because most of the time physiotherapists are involved in providing these experiences. Looking at the basic science, as Dr. Sharma mentioned, I think my previous employer or where I was working, we are participating in 2 randomized control trial. One is improving the inspiratory muscles just to prevent, and the other trial is for expiratory muscle and what NMES was mentioned as a stimulation to the abdominal muscles. So that is another trial. That is the industry-sponsored trial. And the other one is a randomized control trial, which was the funded trial. So I don't know. These are 2 randomized control trial. My previous place of work are participating. And our physios were happy to do that. So as Dr. Sharma mentioned, the proper skill of the physiotherapy, they should have time, not prolonged sessions, but once or twice in a day, those brief sessions, and we have to see whether they are associated with the better outcomes. But yes, this is a meta-analysis is promising, but whether RCT shows benefit or not, we have to see. Yeah.
So more food for thought and more topics for future investigation. So pulmonary rehab definitely will be a very good addition to the quick weaning for such critically ill patient. But yes, more research is warranted to the type, the duration, and the specific functions of the pulmonary rehab. So I would like to conclude this thing with the third trial. We'll be discussing on the Renovate trial. So I would request Dr. Rajiv Jain to kindly start the presentation.
Yeah. So this is the last part of the presentation. So this is a randomized control trial, which the Renovate randomized control trial, which compared high flow nasal oxygen versus NIV in patients with acute respiratory failure, which was published just last month in JAMA journal. So the main aim of this, the main objective was to assess whether HFNO was non-inferior to NIV to rates of endotracheal intubation or death at day 7 at day 7 in the 5 groups of acute respiratory failure patients. It's a multi-center adaptive randomized controlled clinical trial to evaluate the non-inferiority. So non-inferiority trial of HFNO versus NIV, and also assess if there is a potential superiority in reducing the rates of ET or death across the 5 groups, which are non-immunocompromised patients with hypoxemia, immunocompromised patients with hypoxemia, COPD exacerbations with respiratory acidosis, acute cardiogenic pulmonary edema, and hypoxia.
Sorry to interrupt you, Dr. Rajiv.
Yeah.
I can see the slides.
You can't see them.
No. ये पुराना वाला ही आ रहा है, pulmonary rehab वाला ही आ रहा है इसमें.
Okay. Can't see. Now can you see, or it's still the old one?
Yeah, it's still the old one.
Old.
Now I can see.
Now you can see. Okay. Okay, so there basically were 5 groups of hospitalized with a hospitalized patient with acute respiratory failure, and they have compared. We want to evaluate the non-inferiority of HFNO as compared with NIV, and also to assess if there is any potential superiority. Okay, so the inclusion criteria was age of more than 18 years. They were admitted to ICU or to the emergency department with acute respiratory failure. The saturation was less than 90% of PaO2 was less than 60 on room air, and signs of increased respiratory effort either. So almost like tachypnea, like RR of more than 25 beats per minute. Breaths per minute. Exclusion criteria was patient who had an urgent need for endotracheal intubation, prolonged respiratory pauses, a cardiorespiratory arrest, GCS of less than equal to 12, heart rate of less than 50 with decreased level of consciousness, arterial pH of less than 7.15 irrespective of the cause, hemodynamic instability, contraindication to NIVs, vomiting, secretions, a pneumothorax or GCS less than 12, or do not intubate order, or NIV use if in the acute cardiogenic pulmonary edema prior to randomization, a patient was straight away given the NIV, so then they were excluded from this study. So total 2,731 patients were screened, out of which 1,800 were eligible, and 34 finally excluded because of lack of consent. So finally, they found 485 non-immunocompromised patients and 50 immunocompromised patients with hypoxemia. 77 were COPD exacerbation with respiratory acidosis. 272 were acute cardiogenic pulmonary edema, and 882 were with hypoxemic COVID-19. So the high flow was delivered continuously via a flow with that is 30 liters per minute for COPD patients with exacerbation, COPD with respiratory acidosis, and 45 for those in the other 4 groups. And they gradually titrated up to 60 liters or the highest flow which was tolerated. FiO2 was started at 50% and was titrated to maintain SpO2 within 88 to 92% of the COPD group and 92 to 98% in the other groups. And for the NIV, so they started with for COPD group, they started with a IPAP of between 12 and 16, and other groups was between 12 and 14, and the PEEP was kept at 4 for COPD group, and the other groups it was kept at 8. But they had a physician discretion that they can increase the PEEP by 1 or increase the PEEP or increase the IPAP by 1 or 2 centimeter to a maximum of 12 for EPAP and 20 for IPAP. So the primary outcome was endotracheal intubation, and secondary outcome intraremoval or death, and secondary outcome was 28-day mortality, 90-day mortality, mechanical ventilation free days at 28 days, ICU free days at 28 days. And tertiary outcomes were hospital and ICU length of stay with 90 days, the vasopressor free days within 28 days, proportion of patients who do not receive or do not intubate order later on within 7 days of randomization, and patient comfort score. So enrollment began in 2019 November, and so there were multiple interim analyses which were performed, almost 5 or 6 interim analyses which were performed, so that they can find the earlier futility or so then the trial can be terminated if needed. So in April 2021 was the first interim analysis where enrollment was stopped for futility. So when the posterior probability was when they do the non-inferior analysis, when the posterior probability was less than 0.3, the immunocompromised with hypoxemia group, so they stopped recruiting patients there. And enrollment was stopped for a predetermined non-inferiority threshold, which was met in March 2023, the 5th interim analysis for hypoxemic COVID-19 patients, and October 2023 for non-immunocompromised patients with hypoxemia and acute cardiogenic pulmonary edema. But the enrollment continued for COPD patients until the final analysis was done. So these were the results. So endotracheal intubation or death within 7 days was HFNO was 39% versus NIV was 38.1%. So non-inferiority reached in patients with a group of immunocompromised patients, non-immunocompromised patients, COPD, acute cardiogenic pulmonary edema, and COVID-19. And secondary outcomes were none were significantly different for all the 5 groups. Tertiary outcomes, the comfort was superior with HFNO, but otherwise none were different for all the 5 groups. The incidence of severe adverse events was also similar between the 2 groups, 9.4%, the HFNO versus 9.9% in the NIV group. So these were the forest plots of analysis of the outcome. So you have an analysis and a post hoc analysis of primary outcome, where they've compared whether HFNO is better or NIV is better. So the primary outcome, all they passed non-inferiority and showed that it was equally effective on all the groups. But when they did a post hoc analysis of the primary outcome, so this is so they use some borrowing, which is a statistical method where if there are different comorbidities or different. The NIVs used or the intervention used for multiple comorbidities. So when there's borrowing across groups, so the post hoc analysis was done after they were borrowing across the group. So in this, they found that immunocompromised with hypoxemia as well as did not show non-inferiority. So basically it was inferior using HFNO in this group, as well as COPD with respiratory acidosis. The NIV tended to be better, but it didn't reach the non-inferiority margin. So although the results from the primary analysis demonstrated non-inferiority of HFNO as compared with non-invasive ventilation for COPD, but the post-hoc analysis without the borrowing, they produced discrepant results. So the 95%, the intervals were reduced an odds ratio of high as 3.09, which actually suggests potential harm with the use of HFNO. So, the other thing was 23% of the patients with COPD, which were initially assigned to HFNO, they actually required rescue non-invasive ventilation. So, very good amount of patients actually went on to receive NIV. And also patients with acute cardiogenic pulmonary edema who were quite seriously ill, who needed NIV even before randomization, they were actually excluded. So this trial may actually not be generalizable to patients with more severe forms of acute pulmonary cardiogenic edema, which are straight away put on an NIV. But overall mortality, if you compare in general of acute respiratory failure, patients were higher as compared to other studies. So there were factors which the authors concluded that may explain this elevated mortality. First was that probably amongst it's a Brazilian study, so the mortality among critically ill patients has been generally been higher in Brazil patients than in other high-income countries. Second, and this was done during the COVID-19 pandemic, so the patient tended to avoid leaving home. So only severe cases actually sought hospital care. And third, the inclusion criteria for COPD exacerbation required respiratory acidosis. So probably the COPD patients were more severe in this trial. So the limitation of the study was it was unblinded to both patients as well as clinicians, because actually it's not, you won't be able to blind a user of NIV or HFNO. It's not possible. So, and the enrollment in immunocompromised patients was actually stopped for early for futility. So you had very small number of patients in this group. In addition, patients with COVID-19, they were initially not classified as separate group before March 2023. So in the interim analysis, probably the immunocompromised with hypoxemia, a few of them had probably COVID-19, a few of them had COVID-19. So maybe a skewed results here. And the effect estimate relied on borrowing across groups. So this assumes that there is some degree of similarity in the underlying treatment effects. So post-hoc sensitivity analysis without the borrowing shows substantial deviation from main model, particularly the COPD and the immunocompromised patients with hypoxemia groups. But analysis without borrowing, which loses information, and the results in systemic overestimate of the variability of treatment effects across patient groups. Adherence overall to HFNO was good, but it was not much in the NIV group, probably because of patient poor tolerance of patient of the NIV. So median of around 10 to 13. The study, they encouraged that at least for first 24 hours, patient should be on a continuous NIV, but the median usage was only 10 to 13 hours in the NIV group on the day one, despite 24 hours of NIV being encouraged. The comparator intervention was NIV administered through a face mask. So we do not know, they did not address the comparisons with a helmet or helmet delivered NIV or with a CPAP. It was just face mask BiPAP. So the conclusion was compared to NIV, HFNO met the pre-specified non-inferiority criteria, primary outcome of endotracheal intubation or death within 7 days in 4 or 5 of the patient groups with acute respiratory failure. But the small sample size in some patient groups and the sensitivity of findings of the choice of analysis model, they tend to suggest that probably further study are needed, especially in patients with COPD, immunocompromised, and patients with acute cardiogenic pulmonary edema. Thank you.
Thank you so much, Dr. Rajiv, for the excellent presentation. You made such a difficult topic so simple. So, Dr. Nimish, are you there, sir? Dr. Nimish? I think he's not. So I'll request Dr. Paras Jain to share your inputs, your insights on this topic, please.
This trial, I think, comparing high flow versus NIV, I think Again, as we know, in immunocompromised patients, there was a definitely benefit of not intubating these patients and managing on non-invasive ventilation. Then there was a trial that comparing NIV versus high flow came few years ago that showed potentially a high flow not inferior, but surprisingly this trial showed harm with a high flow in the immunocompromised patients. And they stopped early, and it was a very small sample size, hardly 20, 25, 30 patients. COPD, as you see, it is a hypercarbic. Most of those patients are high work of breathing. You expect from a respiratory physiology and mechanics point of view, NIV will perform better in those group of patients. But again, problem with NIV, it is difficult to have a 24 hours NIV. So I usually use an intermittent NIV and a high flow use so that it gets the benefit from both the modalities in a practical, and that is what trial showed, that most of the patients tolerated around 14 hours, also 10 to 14 hours of an NIV, even on the first day when they were short of breath. Unless patient is hypercarbic, we try hard to give non-invasive ventilation. Again, APO, most of the times it is a hypoxemic respiratory failure. You will have benefit with a high flow nasal prongs or cannulae. So again, it showed benefit with a high flow nasal cannula in a patient with APO, but again, they excluded patients with a high work of breathing. So that is one group where I will use CPAP or BiPAP, depending on the work of breathing or depending on the high oxygen. So those patients were excluded. So again, it is difficult to extrapolate those results. So depending on my personal practice is depending on what I am dealing with, hypoxia, hypercarbia, and patient's work of breathing, we make a decision whether patient needs NIV to reduce the work of breathing BiPAP or whether it is a hypoxemia and this one. But as we know, that APO and exacerbation of COPD, where NIV performs better, but looks like high flow is not inferior, or we can use intermittent high flow and non-invasive ventilation help. And that is what usual my personal practice is. Pneumonia ARDS probably no benefit, and this study didn't look at that. But I think this study almost reflects what we usually practice.
Dr. Sharma sir, what is your input regarding this, sir?
Yeah, I was reading this article. I've read it a couple of times just to understand. I had a couple of when you go to the methodology over here, even in see, if you go to actually do a literature search on the incident, the failure rate of NIV, these people, the 35 and 36% failure rate going to intubation or death is pretty high compared to what the world literature actually mentions, So there is a problem. Now, Rajiv did mention, and maybe they themselves have explained, saying that maybe we took more serious cases, maybe COVID-19 affected our, patients were more serious. But your selection criteria was very clear. You were choosing patients who would have been chosen otherwise also, So how does it make it more serious? You have certain criteria. You have a patient who's exacerbated, who's got a pH which is at a certain level, not beyond a certain, because those patients would get intubated anyways. So I'm not very sure whether that you can say that your patients were more severe, that's why your results were very poor. I'm not very sure about that. The other thing is that when you look at their NIV also, the machines that they have given, even the home BiPAP, we all know how these work. You have your servo ventilators and you have your ICU ventilators with inhalation and exhalation valves are different. So when you're giving that with a face mask, the flow dynamics, the ventilator are different from your BiPAP, simple BiPAP that you give. Now, all of us know that in a BiPAP, when you attach there is no inline oxygen. Often it is given through a different port. attached as a different. So really, whether you get the exact pressures that we presume that what pressure setting you have done is exactly what is going, which is a big, because most of and they have allowed either the machines which are invasive machines to be used as, NIV for NIV versus the BiPAP. Even that is allowed. From if you go to the details, they are not differentiated. The second thing is that none of these, though they have said that they were allowing the EPAP to be increased and IPAP to be increased, we do not know exactly whether in these subgroups, whether how much, if there were details of exactly what was the mean pressures that were used in different groups, the EPAP and IPAP pressures, whether they were dealing with a COPD patient or whether they were dealing with pulmonary edema, acute coronary, pulmonary edema situation. What are the mean pressures of EPAP and IPAPs that they were using? It would have made better sense understanding whether they were optimizing the treatment, because it was left to the discretion of the clinician to decide. And there would be many centers where clinicians would have their own way of managing.
So it was not properly standardized also. The machines
I am not very sure, I think or even if it was done, we should have some, what is the mean pressure, whether there was a great variability in the number, the pressures that they were using in different centers, and, in the same group also, whether the things varied, the EPAP and IPAP pressures that they were using were standardized or whether they were, very different. The other thing is that when you look at the COPD also, and they mention, of course, if you take out the boring part of it and you look at COPD, HFNO versus your NIV, you realize that HFNO actually did worse. When you expect that it might be better because patients are more comfortable, you think maybe it will be superior, and you actually see that it's actually detrimental. Those patients did worse or they had to be shifted to NIV. So if you actually go to see a lot of these patients COPD patients particularly, who come with exacerbation and have type 2 respiratory failure, they have a lot of intrinsic PEEP.
Yeah.
They have a lot of air trapping and auto PEEP. And it is common knowledge for somebody who's worked in the intensive care unit that such patients, if they are not on controlled mode of ventilation and you allow them to trigger, that is what happens with the NIV and HFNC. The patient is on breathing on his own, spontaneous breathing. If the ventilator has to give an appropriate breath, it should be sensed. And it can only sense if you offload the auto PEEP, which means your EPAP has to be very close to your auto PEEP before the ventilator can give an appropriate response. Now, HFNO cannot exceed your PEEP is limited in HFNO. It can never go beyond. And experience tells me that a patient with a COPD exacerbation, often you see an auto PEEP of 10 and 12. So how can HFNO be effective in such patients? Because it's not going to help his inspiration, his effort is not going to initiate a breath. And I think that was the main reason why HFNO did not do well in with your COPD patients. So I have a feeling, though this article does say that HFNO is not inferior, it would have been nice to know more specifics of the ventilator settings that they have used, so that it gives us more insight into exactly what. And maybe knowing that, we might have to redo the test with better settings and see whether it makes a difference. For example, when you say that something is not inferior to something, you have to be very sure that, for example, they are saying HFNO is not inferior to NIV. But the question is whether your NIV setting was good enough or whether it was inferior. Suppose you come to realize that their settings were not appropriate or they were not good enough. Maybe the results of NIV were not as good as what you would expect. So if you had better results with NIV, maybe then it would say that maybe HFNO is not as good, inferior. It is inferior to NIV. How do we know that? I think we need to understand what settings were used.
So I think more research is needed on this topic also. So at the conclusion, I would like to thank you, Dr. Sharma, Dr. Jain, for your so lucid explanations and so much simplification of such difficult topics. And I would also like to impart my heartfelt thanks to Dr. Rajiv Jain for such a wonderful presentation. So thank you all. So I would like to conclude this session. Thank you, and have a good day.
Thank you, Paulami. Wonderful session. Thank you, Dr. Rajesh, Dr. Paras for last minute joining. So now we are moving on to next session. Unfortunately, the next section was gastroenterology, but Dr. Jitendra is not available to start the session, and Dr. Amit Vede was also not feeling well. So we have to drop that session as of now. So I'm extremely sorry to the audience for the inconvenience. So we will move on to endocrinology session. So Prajakta, are you there?
Yes. Dr. Tushar sir has joined, ma'am. Dr. Jasmina Vora and Dr. David Chandi sir is also joining in a while. So we can go
Okay.
ahead. Dr. Krishanu, the presenter, he is also here. He has also joined. So we can
Okay.
go ahead with the session.
Okay, so I would like to welcome Dr. Tushar Parmar. He is a Chief Intensivist Critical Care Team and Head of Emergency Department, and very good friend of mine. And he is going to moderate this session, endocrinology. We will include 3 to 4 articles or some publications which has been done in last 12 months, and but related to critical care. And Dr. Krishanu, who is a consultant in critical care department, Sir H.N. Reliance Hospital, he is going to speak about it. He has made a presentation of all these articles. So he will start the session. Dr. Tushar, over to you.
Thank you, Dr. Pritima, for the kind words. Endocrinology being a very important aspect of critical care ever since it has an inception. And last year, probably, we have seen a couple of reviews and a couple of new insights on endocrinology. Typically, if we see that we have seen some amount of personalized glycemic control. We have seen about the adrenal crisis in sepsis and ARDS, and there are some insights on non-thyroidal illness with critical illness. And overall, we have seen an impact on hypo and hyperkalemia and advances of their management with long-term sequelae of endocrine. I welcome all other esteemed guests over here, and we'll start the session and we'll go with the presentation by Dr. Krishanu. Dr. Krishanu, over to you. Please start the session, and we'll go with the rest of the discussion in between the session. Thank you.
Good evening, everyone. So today we'll be taking up 2 topics regarding the endocrine issues of critical care. So one of them is thyroid critical illness, and the other one is adrenal insufficiency in critical illness. So coming to first, the non-thyroidal illness syndrome. So it was previously known as the sick euthyroid syndrome. So most commonly it is characterized by a low T3, a low or low normal T4, and a low or normal TSH. So this is the most common scenario in sick euthyroid syndrome. However, recent studies and evidence, it has shown that patients may have acquired transient central hypothyroidism during the critical illness. So these changes in the thyroid functions, that is a low T3 and an elevated reverse T3, these are usually a protective mechanism which prevent excessive tissue catabolism. And the T3 assays should have a detection limit of 0.01 milliunits per liter to assess the thyroid function. So these are the following changes that take place in the thyroid hormones during critical illness. So first of all, in the TSH, so usually a number of drugs which are commonly used in the ICU, like dopamine, dobutamine, high dose glucocorticoids, they lower the serum TSH. And usually the TSH is in the range of 0.08 to 0.4. If it is less than 0.01, so mostly it is pointing towards hyperthyroidism. But in sick euthyroid syndrome, it is ranging between 0.08 to 0.4. Various cytokines that are released during critical illness and the inflammatory state, they also lower the TSH level by reducing the hypothalamic hormone TRH, that is the thyrotropin releasing hormone. And also there is a blunted nocturnal rise in the serum TSH response to the thyrotropin hormone. In the total T4, so the total T4 is also low. So this is because number of proteins like the albumin, thyroxine binding globulin, transthyretin, and thyroxine binding prealbumin. So these proteins are reduced in critical illness. And also number of circulating substances, particularly free fatty acids, they also inhibit the T4 binding to the protein. So the total T4 is low. In case of free T4, so it may be either normal, it can be increased or it can be decreased. However, the total T4 level measurement, it is more informative in case of critical illness than measuring the free T4 levels. Coming to T3, so the free T3 levels are low. So this is because of the reduced activity of the monodeiodinase 5' monodeiodinase enzyme. So that peripherally converts the T4 to T3. So particularly in critical illness, when the caloric intake is low, so the activity of this enzyme is reduced. And a number of other factors like cytokines, endogenous cortisol, and drugs like amiodarone, they can also decrease the activity of the 5' monodeiodinase. And conversely, the reverse T3 levels, they are increased. So this is because the D3, that is 5 monodeiodinase enzyme, that is induced in non-thyroidal illness, particularly in the setting of hypoxia and ischemia, which are common in critically ill patients. And also there is a reduced clearance of the reverse T3 due to decreased activity of the 5' monodeiodinase enzyme. So these are the various changes that take place in the thyroid hormones in critical illness. So we can see in this graph that as the condition or the clinical severity of the disease increases, so we can see that the free T4, TSH, and T3, these levels are suppressed to much lower levels than as compared to the normal range, and we can see that the reverse T3 levels are usually increased in the very sick patients. So conditions which are associated with non-thyroidal illness syndrome. So a number of drugs which are commonly used in the ICU like dopamine, dobutamine, glucocorticoids, furosemide, NSAIDs, heparin, metformin. So they can again affect the thyroxine binding globulin and in turn affect the thyroid hormone levels. Disorders like hepatitis, hepatoma, AIP, acromegaly, nephrotic syndrome, psychosis, and depression. So they can also cause non-thyroidal illness. So coming to the evaluation of non-thyroidal illness, so the main aim is to recognize the non-thyroidal illness and differentiate it from any underlying primary thyroid disorders. So most commonly, the initial set of tests that we do is the TSH level and the free T4 levels. The total T3 and T4, they are optional initially, but they can again help us to come to a rapid diagnosis. So after doing the TSH level, so we can have three settings. The TSH may be either subnormal or it can be high or it can be normal. So any of these settings can happen in a sick euthyroid syndrome. So if the TSH is normal, then we go for the free T4 levels, and it is usually low in case of non-thyroidal illness, and it should be reassessed after the illness. So after around 1 to 2 weeks of recovery, we can assess, and if we find it is normal, then it again indicates to a non-thyroidal illness. And along with that, we can also do a serum cortisol level to rule out the central hypothyroidism. So critical illness can usually associated with a high serum cortisol levels. And on the other hand, if there is a underlying true central hypothyroidism, so serum cortisol will be low in that cases. So if the TSH levels are subnormal, so then again, according to the levels of the TSH, So if the TSH is markedly reduced, that is less than 0.01, so it invariably points out towards the thyrotoxicosis. And if the TSH levels are like less than 0.05, and along with that, if FT4 is elevated, then we should do a total T3 and T4. So again, if the T3 is high or high normal, then it indicates hyperthyroidism. But if it is low, then it indicates that it is a critical illness related thyroid disorder. And if the TSH is between 0.05 to 0.3, and along with that, if the free T4 levels are low or normal, so then again it is we have to reassess after 1 to 2 weeks. And again, serum cortisol levels can be assessed to differentiate it from central hypothyroidism. And reverse T3 levels, this is also very rarely used in a clinical setting, but it is usually increased in a critical illness. And a high TSH level, so this is usually seen during the recovery from the critical illness, during the recovery period. So if the TSH levels are above the upper normal limit to less than 10, so then again we have to repeat the TSH after 1 to 2 weeks. And if the TSH is between 10 to 20, so depending upon the free T4 levels, we can consider treating with levothyroxine if we are suspecting there's a high suspicion of underlying hypothyroidism. And then we can repeat the TSH after 1 to 2 weeks of recovery. And if the TSH levels are more than 20, so then most likely diagnosis is hypothyroidism primarily, and usually associated with a low T4 level. So we should initiate the thyroid hormone supplementation. And if FT4 levels are normal, so then again it can indicate a critical illness thyroid disorder. So repeat the TSH and free T4 after 1 to 2 weeks. So this is a review of the meta-analysis. So whether the non-thyroidal illness should be treated or not. So in this review of the meta-analysis, so it is still there's a debate whether such patients should be treated with the thyroid hormones.
Dr. Krishanu, I'll take a pause over here and we'll go with the panel for a discussion. I'll first invite Professor Joshi about we've been talking about sick euthyroid since long, and probably we have not been treating the sick euthyroid for a long period of time. Any views on that, sir? Any new updates from your side where we can guide into a thyroid illness with acute intensive care treatment? Please, sir. I hope Dr. Shashank Joshi is here.
Sir, he is joining in a while.
Okay. My question is to Dr. Jasmina. The way we have started the diagnosing non-thyroid illness in acute crisis, whether we should be relying on all that investigation in this scenario, or we are just still going in a blind to diagnose the non-thyroid illness. Any views on that?
Yes, so non-thyroidal illnesses has been a burning issue, honestly, for many years. And more or less, the conclusion also has been similar over years. Because as Krishanu rightly presented, there were certain cutoffs. I do agree with those cutoffs. I mean, at the extremes of TSH, say very low TSH, less than 0.01, a primary thyroidal illness is more likely than a sick euthyroid state. Similarly, a TSH which is obviously very high, going to more than 15 or 20, I don't think we should treat rather than thinking or overthinking. However, in the middle range, especially in the low TSH zone, so low TSH with a low free T4 is sort of body's protective mechanism in any critical illness, because the body wants to reduce the metabolic rate and reduce the wastage of important energy and nutrients. That is the sort of compensatory mechanism. So that is why it is not recommended to treat each and every low free T4 or low TSH that we come across in a critical setup. And that recommendation continues till date. The exception would be patients who are like who have been given Corderon. So a very high dose of Corderon infusion or oral Corderons, or patients who are there in ICU for prolonged time and they are running tachyarrhythmias. There may be our we have to take a case to case decision and then decide as to what we want to do with it. Yeah.
Thank you very much. My next question to Dr. David. Dr. David, there is not been a standardized way to, I guess, follow through every trial which is related to thyroid. There are some say that we might have to go with improvement in cardiac index. Some say that oxygenation improvement. Some say that mortality, morbidity. What is your take that if at all we are going with any randomized trial or anything else, what should be the aim for the study and how we should be approaching for any thyroid illness in critical care?
So, like, Jasmeena madam had said that, it is not a well-defined entity. huh? It is still like, only if you have cases which are classical in terms of their symptoms, like you have tachycardia, or if you have bradycardia or hypothermia, you're sure of the diagnosis. Like Krishnanu said, like, there's a lot of ambiguity about which test to follow. Like, for example, free T4 versus total T4. So right now, there's still an intense debate between the two. What has been well defined right now is in severe cases, critically ill patients which are near morbid, like severely morbid, near mortality, the free T4 starts going down. So in terms of very severe patients, they say that rely more on free T4. That is when it starts going down. It can be in fact, an indicator of near mortality. In the other terms, like there is a lot of data being analyzed in terms of, the cardiac parameters. Can they be used for research? The temperature, but all of them are in the very early stage. We don't have any clear zone, to proceed with research as of now.
Thank you. Any other comments on NIST from both of you? If there is something you want to have an insight before we go for the next paper.
So I would say we should leave it. Yeah, David, please go ahead.
So just like, in a ICU, most common, like Krishnanu mentioned, is steroids. Many times when steroids are going, we like, rely too much on TSH.
Yes.
So that's one thing, like make sure that, steroids are ruled out as a cause. And the second one point, like, many times we have patients with low albumin. Like recently in ICU for 2 months, we had a patient who had severe nephrotic syndrome.
Okay.
So in those patients, like, it's very important that we follow the free T4 because the thyroid binding globulin goes down. And in fact, in those patients, it is known to go so low that the patients have lost thyroxine through the urine because of thyroid binding globulin going out from the urine. So in such cases, like, you have to be more aggressive, look at free T4 and, in those cases, maybe adjust the dose looking at free T4.
Yes. So one of the studies, I think so in 2014 or so, they have seen the remission of nephrotic syndrome as well related to thyroid hormone supplementation. So I'm not sure how that study was well randomized or what, but they have focused on the part of an renal recovery as well. Sure. Anything, Dr. Jasmeena, from your side?
Yes, I just wanted to add that a very low free T4 level, for example, something like 0.3, 0.4, I have seen patients who've like genuinely had a central hypothyroidism, honestly, in that scenario, for whatever reason. And so very low free T4, we should give a little more attention rather than just ruling it out as NTIS probably, depending on the case.
Sure. Thank you very much. Dr. Krishnanu, we
Yes,
can
sir.
proceed further.
Yes, sir. Yes, sir.
Yeah, thank you.
So this is just a recent paper. So where two pilot placebo-controlled randomized trial was done. So where there was a triiodothyronine hormone supplementation in a septic shock patient with NTIS. So here it was found that the T3 supplementation was associated with a 28-day lower 28-day mortality, but that was particularly seen in a subgroup of patient which was having both low T3 and T4. But then it was again associated with increased mortality in that subgroup of patient with only low T3. So basically, we are having ambiguous results, like ma'am and sir just informed us. So this is the management recommendation. So critically ill patients with a low T3 and T4 who do not appear to have a primary underlying thyroid disorder, we usually should not treat them with a thyroid hormone. So T3 replacement can result in an increased catabolism or breakdown of the skeletal muscles in fasting state, which is common in critical illness. And again, N-acetylcysteine, which is an antioxidant. So in the randomized trial, it was found that this with the N-acetylcysteine, it can ameliorate the fall of T3 and the rise in the reverse T3. So this is also very new in the treatment lines. And also during and after the cardio bypass surgery, so there is a transient decrease in the T3 concentration. So it can contribute to a post-operative hemodynamic problems. But in clinical trials, the supplementation of T3, it has not shown to have any improvement in outcomes of cardiopulmonary bypass. So coming to the next topic of our discussion, that is critical illness related corticosteroid insufficiency. So in this review article, in critical illness, related corticosteroid insufficiency is very common in ICU setting. So it is seen in nearly 30% of the ICU patients, and it has significant implications regarding their treatment and overall outcome of the critical ill patients. So in critical illness, it is a kind of a relative adrenal insufficiency. So adrenal production of the cortisol hormone is insufficient to meet the body's demand during the times of stress. So any sepsis or inflammation, it results in an increased stress in the body. So that results in production of cortisol. But in critical illness related insufficiency, so there is inadequate production of the cortisol hormone. So like I said, there is a 30% incidence among the ICU patients, and usually it is manifested as an exaggerated inflammatory response. So adrenal insufficiency, the number of pathological mechanisms have been attributed to its cause, primarily being the impaired functioning of the hypothalamo-pituitary adrenal axis. And there is also an altered cortisol metabolism and also increased tissue corticosteroid resistance. So in this chart, we can see the pathophysiology. So in the early phase of critical illness, any inflammation or sepsis which activates the hypothalamo-pituitary adrenal axis by producing the corticotropin releasing hormone from the hypothalamus, that in turn stimulates the pituitary release of the ACTH, which stimulates the adrenal gland to produce the cortisol. So this is the stress hormone. But after a prolonged critical illness, like around 4 weeks, there is a down regulation of this hypothalamo-pituitary adrenal axis characterized by low ACTH levels, and ultimately there is decrease in the cortisol production. And another mechanism is like there is altered cortisol metabolism and altered cortisol function. So it can lead to hypercortisolemia because there is reduced albumin, and also there is decreased binding of the cortisol to the cortisol binding protein. So this and also reduced breakdown of the cortisol in the liver and kidneys. So this results in increased cortisol levels. So that in turn can have a negative feedback effect on the HPA axis and further causing decreased production of cortisol. And also in sepsis, there is a peripheral resistance to the cortisol. So that can result in a corticosteroid insufficiency. And so the glucocorticoid receptor, so there can be an imbalance of the glucocorticoid receptor. So there is an upregulation of the glucocorticoid receptor beta, so that as compared to the alpha, so that can again further cause tissue resistance to the cortisol and causes the cortical insufficiency in critical illness. And a number of, again, drugs which are used in critical illness, like the opioids or the azole psychoactive drugs, so they can directly have a suppressing action on the HPA axis, and it can lead to a SERCE. So these are the various mechanisms resulting in the critical illness in related corticosteroid insufficiency. So coming to the presentation, so it is very non-specific. So like fatigue, weight loss, syncope, fever, or some mental changes can occur, cramps, or postural dizziness, etc. So severe cases, there can be hypovolemic shock and coma. And there can be encephalopathy, poor neurological recovery after the stopping of sedations, and persistent requirement of the vasopressors. So these can all indicate a SERCE. And usually on imaging ultrasound, like the adrenal gland volume, so it is seen as less than 10 centimeter cube, particularly in patients of septic shock. So this has been found with associated to be increased mortality. So diagnosing, so there is no reliable laboratory test that helps the clinicians to use a glucocorticoid replacement therapy in critically ill patients. So the plasma cortisol levels random, and also like the ACTH stimulation test, the response of that test to the cortisol level, so they are very unreliable in critically ill patients. So in an American Endocrine Society recommendation, so they have said that if the cortisol level is less than 18 micrograms per DL after 30 to 60 minutes of a high dose posintropin stimulation, that is 250 micrograms, so that can indicate towards a SERCE. And according to the European and the American SCCM guidelines, so if the change in the baseline cortisol is less than 9 micrograms in 60 minutes after the administration of a high dose ACTH stimulation test, and a random cortisol levels less than 10 micrograms per DL, so in such scenario, there is a likelihood of adrenal insufficiency in ICU patients. So in whom to suspect SERCE? So particularly in very sick patients, like patients on mechanical ventilations or high dose vasopressors seen in the ICU for longer than 4 weeks. So in such patients, we should suspect. So the hemodynamic instability is going on with increasing NORAD or vasopressor requirement despite proper resuscitation, and use of various medications like opioids, etc., that can affect the cortisol synthesis. So again, labs features in critical illness associated corticosteroid insufficiency very non-specific, like hyponatremia, normocytic normochromic anemia, lymphocytosis or eosinophilia, hypoglycemia, hypercalcemia. So normal or low cortisol levels can be seen, low albumin and cortisol binding globulins. Normal or low ACTH levels can also be seen. So that is why cortisol and ACTH levels are not very reliable. And again, so at the time of presentation, we can go for some cytokine analysis. So if these are increased, so that can be a non-specific indicator. So coming to like treating the critical illness related in corticosteroid insufficiency. So we have to select the patients whom we could start with a glucocorticoid therapy. So particularly septic shock patients, due to conditions which can benefit from glucocorticoid therapy. So these patients like were suffering from acute eosinophilic pneumonia or hemophagocytic lymphohistiocytosis. So these in such patients we can start a glucocorticoid therapy. Other causes are refractory ARDS, not responding to initial lung protective ventilation, severe community acquired pneumonia, and COVID-19. So in such patients with septic shock, we can initiate a glucocorticoid therapy. So refractory septic shock, that is low systolic blood pressure less than 90, even after 1 hour of adequate fluid and vasopressor administration. So in such patients, we have to initiate the hydrocortisone infusion. So routinely, we should not start as an initial therapy of corticosteroids. First, we have to try to assess the patients with septic shock and manage them with fluids and vasopressors. Only if it is not responding even after 1 hour, then we can start. And in patients with severe influenza, so it is seen that corticosteroid infusion may have detrimental effects. So severe influenza patients may not be treated with a corticosteroid infusion. So coming to a few studies, so data have consistently shown that corticosteroid therapy, it has resulted in a faster resolution of shock, but mortality benefit is unpredictable. So it has been seen that early administration, that is within 12 hours of presentation, they provide maximum benefit when we are initiating the treatment. So 2024, there was a meta-analysis of 17 trials. So where they compared fludrocortisone and hydrocortisone versus only hydrocortisone. So a combination regime was associated with 12% reduction in all-cause mortality. And also the Society of Critical Care Medicine in America, they performed a meta-analysis that also recommended the use of glucocorticoids in refractory shock. So some randomized trials which used the regime of hydrocortisone and fludrocortisone. So in there was this trial in 2002, that was a French trial that used 50 milligrams of hydrocortisone QID and 0.5 milligrams of fludrocortisone once daily for 7 days. So they saw a mortality benefit as compared to the placebo. So there was the Approaches trial in 2018. So the vasopressor dependent septic shock with the combination regime, it showed a decreased 90-day and a 180-day mortality. And there was a coitus study which was again compared to hydrocortisone alone with the combination regime. So the absolute risk reduction was 3% with the combination therapy. And there are other trials which assess the use of hydrocortisone alone, like the Corticus trial in 2008. So it showed a faster resolution of the shock, but there was no difference in the 28-day mortality. Again, there was a Vanish trial, so where the hydrocortisone was added in patients either receiving vasopressin or noradrenaline in septic shock, but again, it did not show a mortality benefit at 28th day. So other trials like adrenal trial and Hypress trial, so these also trials did not show any particular difference in mortality at 28 day and 90 day. So these are the summary of various trials and studies done in regards to the CERSI. So coming to treating.
Yes. I'll just take a pause on that.
Yes, sir.
Yeah, Dr. Jasmina, what is your take on therapeutic threshold? What we have written over here is less than 400 milligram intravenously. Are we still under treating the steroid deficiency, or are we at par with the overall treatment protocol? Whether we talk about the refractory shock or whether we talk about the septic shock and reversal of the refractory.
Yes, so I would say the cutoff of 400, what they have chosen is a little bit high. And in critical care, because it is always a mixed scenario of multi-organ failure, septic shock, and other illnesses, also the diagnosis of corticosteroid insufficiency is also ambiguous many times. So we do not go to a dose of 400 milligrams per day of hydrocortisone, honestly. So a dose of 200 milligram per day is what is known to show the desirable outcome, whatever we want, as it is the ultimate mortality outcomes in various studies have not showed significant benefit. So a dose of 200 milligram per day of hydrocortisone is what we choose. Addition of fludrocortisone again would depend patient to patient, because there are many patients where we already have issue of fluid overload or a cardiac instability kind of places where we are not very happy with them. Having said that, a high index of suspicion in terms of recurrent hypoglycemia and hyperkalemia, these are the two things where we have found that there is genuinely a corticosteroid insufficiency, and these are the patients who have really benefited by starting replacement in critical care setup.
Thank you. Next question to Dr. David. Dr. David, we've been using methylprednisolone quite long. What we are discussing about in ARDS and many kind of sepsis where lung are involved. So there we are trying to focus on dual benefit. One is an inflammatory portion of it, and second is an probably shock and reversal of shock. Uh, we have seen a lot in COVID-19. What is your take on how have you have seen the post effect of the methylprednisolone coming to your clinic many a time after what we say as an follow-up or an they come as an routine OPD to you who has taken a methylprednisolone in a larger doses and now they are facing a complication. So how do you rate them and what complication you have seen after the steroid therapy?
Okay. So in most cases over here, the steroids are given for a short time. So when steroids are given for a short time, it does not matter. But if it's given for a very long time, for a long duration, more than 2 to 3 months, then definitely it starts having an effect on the bone metabolism. And what studies have shown, there have been 7, 8 trials which have compared both methylprednisolone or prednisolone versus hydrocortisone. Hydrocortisone is much milder on the bone. So for long term, when we consider for bone metabolism, hydrocortisone has more safety data. Usually, when we taper the steroids and we try to go off the steroids, we normally prefer methylprednisolone. It is easier to titre, and if at all we are doing the labs, your methylprednisolone will suppress the cortisol, whereas hydrocortisone is nothing but cortisol. So it's easier to monitor the cortisol while the person is taking hydrocortisone.
Because I think so the recent paper what I've gone through is endocrinopathies in post-ICU patient, where they have found insulin resistance and gonadal dysfunction as well as HPXS deficiencies. That's been little common in a post-ICU. And nowadays, if we see there are 40 days, 45 days, 60 days of an intensive care where they go through many as episode of sepsis and septic shock. One more important aspect, when we are going with steroid therapy, what are the implications, what we need to watch for I would say, going to an electrolyte imbalance as well as their insulin requirement? Dr. Jasmina, if you can just
Yes, so
guide on that.
So when we are using steroids in an ICU setup or otherwise also, obviously the insulin resistance worsens, and typically it is the post-meal sugars which start behaving very abnormal. And addition of an intermediate or long-acting insulin whenever possible, we have to do because the insulin requirements significantly increase. As far as the electrolyte imbalance is concerned, treating with very high doses of steroids, one has to be watchful with the electrolyte imbalance in terms of hypokalemia and hyponatremia, etc. Because I mean, from case to case again. So high dose steroids, the patient is put into a Cushing's-like situation. Wherein the low potassium further weakening the muscle weakness and difficulty in weaning the patient off the ventilator, etc. So that is how the electrolyte imbalance also has to be monitored.
You've gone to the steroid trial. To reconfirm, Dr. Shashank sir is there or he has not joined. Probably we are trying to get to him. Get a certain insight on that. One more interesting article what we have gone through, though this is not the part of what we are discussing right now, is uh, uh, targeted treatment for hypokalemias and targeted treatment for hyponatremia. This is the recent part of the study which we have gone through. Any insight on that, Dr. David, for the same?
So, like with respect to your steroid replacement,
Endocrinologies, targeted
so with
treatment.
respect to steroid replacement, like dexamethasone is a pure glucocorticoid. So if
Yes.
you have a patient like where you're worried that with a high dose steroid you will worsen the person's potassium, you will cause hypokalemia. So over there, like one option is you can use dexamethasone. That will not have any mineralocorticoid effect. Okay. So that is one thing that you can keep in mind, like, if at all you are dealing with such patients where you want a pure glucocorticoid effect, without causing much of electrolyte imbalance, dexamethasone would be a good option.
Also, deflazacort might help where we are worried about the side effects and all.
And
You can continue, Dr. Krishnan, for last couple of slides, I guess.
Yes, sir. Yes, sir. So,
one moment. One in the diagnostic part also, there's one interesting point
Yes.
that we have to
Yes.
come on before we move ahead. So if you look at the traditional diagnostic criteria, where you do the synactin or the cosentropin test, the cutoff always has been mentioned as 18 if you go back to it. But now in the
Yes.
last 1 year, there is a lot of data that, that has been questioned. When you do the synactin stimulation test, you have two platforms where you do it. You have the monoclonal antibody, like Roche and Abbott platform, and you have the polyclonal antibodies, like, you have the Beckman Coulter and the Siemens. So among the two, if you see in the monoclonal antibody, the threshold, multiple studies have shown a cutoff of 14 microgram per DL. So in our hospital, we have recently changed the cutoff to 14 at the 30 and 60-minute cutoff. Traditionally, for many years, it was 18. So we use Roche platform. So depending on from which lab you're doing the sample, you need to check whether it's a monoclonal or a polyclonal antibody, and then proceed with this diagnostic cutoff of 18.
Okay.
Okay.
That's one thing I wanted to add. We'll go ahead.
So coming to the treatment part, so mostly as ma'am said, we use particularly in the ICU of 200 milligrams in 24 hours. Mostly the regimen that we use is a continuous infusion, but we can also give it as a bolus regimen also, as 50 QID or 100 milligrams of hydrocortisone TDS. Fludrocortisone, again, in critically ill patients, there is a limited enteral absorption. So that is also in sick patients, we usually the efficacy is questionable. And alternative steroids, like if the patient has cerebral edema, for which we are giving dexamethasone, or in COVID-19 ARDS, so equivalent dosing of dexamethasone should be used, like for 200 milligrams. And methylprednisolone, it has limited data in management of CIRSE, but in moderate to severe ARDS, one study reported the use of 40 to 60 milligrams IV daily. So usually the duration of treatment is usually 5 to 7 days, and the tapering is usually not required, because in most of the cases, like in steroids, we go for tapering dose, but in CIRSE treatment, the tapering is not required. But if there is a rebound hypotension after stopping the steroids, so then we can restart the steroids and we can initiate further evaluation of the cause of shock. So coming to the adverse effects, like ma'am told us, like usually from steroid supplementation, it can cause hyperglycemia, hypernatremia, fluid retention. Also, there's increased susceptibility to the nosocomial infections, neuropsychiatric like ICU delirium or some other neurological manifestations like ICU acquired weakness. So these are the common adverse effects of the steroid therapy.
I think
So
GI bleeds also we should keep in mind, because
yes, ma'am. Yes, ma'am. So with this, we end the presentation. Thank
Great.
you, everyone.
Thank you, Dr. Krishanu. Thank you, Dr. Jasmine. Thank you, Dr. David.
thank you so much.
Any insight, any last golden words from each of you for us to be wary of how we should be going with an endocrinology and intensive care would be great. Please.
David would be the right person to talk about.
I just remember my professor's words, when we would go for ICU rounds, he would say, unless you have strong clinical suspicion, don't order thyroid test and cortisol. Many times it will be misleading.
It'll
So,
always be wrong,
That's a
correct?
great one.
so you
Absolutely.
need to have very strong clinical suspicion
Then
and
only
then
ask
go
for
ahead
it.
and ask for the test. That would be like, my take on it. Madam, what?
Absolutely, I agree. Every time you ask for it, it's bound to be abnormal.
Hmm.
And then you don't know what to do with it.
And like is low T3, like the other name for, the sick euthyroid syndrome or non-thyroid syndrome. For the students, just remember it's also called as low T3 syndrome. So remember the first clinical symptom or the first lab abnormality would be a low T3.
Low T3.
So lots of times from ICU, like, we get sometimes a reference just the T3 is low. So that is the expected response. Nothing needs to be done. But if the TSH is very much out of, target, or again the free T4 is very much out of target, like Madam said, then definitely you need to be more careful.
Sure. Thank you. Thank you very much.
Thank you so much.
Thank you. Thank you, Krishanu. I'll hand it over to Dr.
Thank you, sir.
Pritima for the
Thank you.
same. And thank you very much. Thank you, everyone.
Thank you so much, all the panelists, for the wonderful discussion. Thank you, Dr. Tushar. Unfortunately, Dr. Chandrima could not join, so we have to end it here. I think this was the last session of this program. It was a wonderful journey of last 12 months, which we have tried to compile in 4 days, and I think it went well. Unfortunately, Dr. Arindam is still not there, I believe. Sir, aap hai, Dr. Arindam? No. So anything, we are done for this session. Thank you so much, everyone, for joining us. Next year, again, we will come back in 25, 26. The last 12 months, again, we will gather all the information, the new updates and everything, and we will discuss in first or second week of January 26. Thank you so much.
Thank you.